It's 12 o'clock. Please sit down. I would like to officially start our conference. It's my great honor and pleasure to welcome you at the 13th International Conference on the complex treatment of plasma cell dyscrasia here at the historical Jagiellonian University Medical College of Krakow. I would like to welcome our rector, Professor MACIEJ MAۯECKI. I would like to welcome our former chief of the Department of the Hematology Clinic, Prof.Aleksander Skotnicki. I would like to welcome also rector of the Pomeranian University, Professor Bogusław Machaliński. And also I would like to welcome our distinguished guests from many countries. We have Professor RAFAEL FONSECA from famous Mayo Clinic. Welcome. We have also Professor ERINI KATODRITOU from Athens, from Thessaloniki. Welcome. We have also MEERA MOHAN from Wisconsin University, United States. Welcome. Welcome, Professor Tomasz Sacha, also our Chief of the Department of Hematology, Krakow. We have also Professor Michael O'Dwyer from Irish University. Welcome. And we have also Professor CHOR SANG CHIM from University of Hong Kong. Welcome. Welcome other guests and colleagues from many countries and from many places like Lublin, like Wrocław, Szczecin, etc. Krakow is not only our host city, but also the city of science, culture, and memory. Just outside these walls, medieval streets and Renaissance Square remind us that this city has, for centuries, has been a place where scholars, physicians, and thinkers gather to exchange ideas, to push the boundaries to knowledge. Nicolaus Copernicus, you see him on the behind, himself studied at this Jagiellonian University, daring to challenge the knowledge universe. In the same spirit, we gather here to challenge disease, to challenge limitation, and to improve the lives of our patients, which are here at this place. Our focus during these days is plasma cell dyscrasias, especially multiple myeloma. This is a disease that only a generation ago seemed to leave us with very limited tools. Yet, science collaboration perspectives, now we stand at a point where CAR T-cell therapies, bispecific antibodies, immunotherapy, refined algorithms of care are no longer just research concepts, but real options, changing the natural history of this myeloma. What makes the conference unique is not only the depth of the science, but global perspectives represented in this room, experts from United States, Europe, Asia, and beyond. Each of you brings insight from different healthcare systems, different patient populations, and different clinical experience. Together, we form true international community, united by a single mission to bring longer survival, better quality of life, and ultimately a cure for our patient. Cure is possible in myeloma. As we exchange ideas over the next day, let's remember the science flourished not only the lecture halls, but also the conversations shared over coffee and questions during discussion, even during walk through the old street of Krakow. These stones of this city have witnessed centuries of dialogue and discovery. May they inspire of us. Finally, let me extend my gratitude to the distinguished speakers and each of you traveling to this important gathering. If your dedication makes progress possible, thank you for our sponsors, GSK, Pfizer, Johnson, Biocom, Amgen, Bristol Myers Squibb, and thank you for honorary patronage from President Aleksander Miszalski, from Wojewoda Małopolski, and from Marszałek of Małopolska, and also Rector Piotr Jedynek. Thank you for honorary patronage. Thank you also for this conference Jordan Group, especially Agnieszka Grzesiak and Eva Bochenek, who helped us to organize this event. On behalf of the hosts, I warmly welcome you in Krakow. May the conference enrich your knowledge, deepen the collaboration, and leave you with lasting memories, both science and beautiful city of this place. Thank you, and start knowledge. Thank you. I would like to ask our rector, Professor Maciej Małecki, to open the conference.
Dear Professor Jurczyszyszyn, dear colleagues, I would like to join Professor Jurczyszyszyn in welcoming you here in Krakow. No matter what country, what city are you coming from, you are equally welcome here in our former capital. Thank you very much for coming here. Special warm words of gratitude should come to the lecturers. Thank you very much for coming, for sharing your expertise with us. It is very important for our university and I think for the entire group of participants. As Professor Jurczyszyszyn said, we are the oldest academic institution in Poland. The medical school was established together with the entire Jagiellonian University in 1364, and we are very proud of this past. You can see Copernicus's picture on the back wall, 1 block away from here. There is a museum of the Jagiellonian University. However, we are looking not only to our past, but also to our future. We have a very beautiful medical campus in the Prokocim quarter of Krakow. We have the new university hospital, and we are very proud of the departments that are located there, including hematology department. So Professor Jurczyszyszyn, Professor Saha, and the entire team, we are very proud of your achievements. So let me wish you a nice stay here in Krakow, although the weather is a little bit cooler and more rainy than over the past week. I know that Professor Jurczyszyszyn organized a dinner outside of Krakow in the reconstructed medieval castle, so I'm sure that you will be leaving Krakow and our medical school not only full of good scientific memories, but also of the social program. Thank you very much.
Thank you, our rector. I would like to ask President Michalski, assistant, to welcome.
Dear organized, distinguished guests, I'm pleased that once again our city has the honor of hosting a forum for scientific discussion and the exchange of experience among outstanding global specialists in hematology and immunology, the participants of international conference. I'm convinced that Krakow, one of the most frequently visited European metropolises, and at the same time a prestigious center of the development of innovative medicine, will be a worthy host of this important gathering. As a city of historical memory and new opportunities, Krakow has earned its status of an international center of culture, art, and science through centuries of serving as Poland's capital and the seat of Polish kings. It is with great pleasure that I welcome this distinguished gathering of medical professionals and scholars. Proud of Krakow, a unique atmosphere which provides the finest conditions for both work and rest, I trust that the beauty of our city will make your stay not only productive, but also truly enjoyable. I wish you fruitful deliberations and hope you will live as friends of Krakow. With warm regards and best wishes for a successful conference, Aleksander Miszalski, Mayor of the city.
Thank you very much. I would like to ask our chairmen, Professor Skotnicki, Professor Grosicki, and Dr. Steckiewicz to start first session. Our conference will be divided on two sessions. First session will be now, later will be lunchtime, and later will be second session. So the conference is open. Thank you.
Before we open scientific part of our meeting, let me remind the event which took place in this very place about 30 years ago when Nobel Prize winner Professor Donald Thomas from Fred Hutchinson Cancer Center in Seattle, Washington State in America came to open our bone marrow transplantation center. He was staying here, looking around, and suddenly he looked at Copernicus and he told, yes, you will make Copernican revolution in hematology. And it happened, starting especially in immunotherapy era, starting from the use of, in the therapy of multiple myeloma patients, biological response modifiers, the therapy which modified immune system through graft versus myeloma in patient with subjected to stem cell transplantation, through monoclonal antibodies, anti-CD38, until CAR T cells. So it's absolutely in front of our eyes. Us, a little bit older scientist, I am the oldest hematologist in Kraków, I was very pleased to see that our patient could be, if not treated completely, but they could survive for many, many years, starting from 3 years until 15, even 20 years in our department, as well as in Wisconsin, where we are from. So we are taking part in wonderful progress in worldwide medical science, including hematology. So thank you very much, and I will start our session in a minute. Our first speaker came from United States, and she's expert in multiple myeloma, MEERA MOHAN, and she will be telling us about CAR T cell in multiple myeloma outpatient administration. Even some title is special, how to take care about patient in outpatient situation with very intensive therapy, which taking part in our scenario of helping our multiple myeloma patient. So MEERA, the stage is yours. Thank you for coming to Kraków, and I hope your way to share your knowledge will be well accepted by our audience. Thank you very much.
Good afternoon. I want to thank Arthur and the entire team for the kind invite. I also want to express my sincere gratitude for the opportunity to visit your country and share this unique culture here. It's really an unforgettable experience. So my topic today is CAR T cell therapy in multiple myeloma, outpatient administration. These are my disclosures. So the agenda for today's talk include a brief overview of the US FDA-approved products for multiple myeloma, followed by some of the early and late complications with CAR T cell therapy, I'll go over patient selection and infrastructure requirements for outpatient CAR T-cell therapy, models of outpatient CAR T-cell therapy, and a couple of real-world experience of patients that I've treated as an outpatient. We know that CAR T-cell therapy is actually a treatment pathway, so I want to briefly go over the journey of CAR T-cell therapy. The first step is to identify a patient who's a potential candidate for CAR T-cell therapy. In our setting, this usually starts in a community setting where a patient is kind of identified by the community oncologist as a potential candidate. Just like with transplant, in general, a patient is considered an ideal candidate for CAR T-cell therapy if they have a decent performance status with an ECOG score somewhere between 0 to 2 and adequate organ function. So once a patient is deemed a candidate, they are referred to the CAR T-cell center where we will further evaluate the patient. The patient will undergo disease evaluation, organ function evaluation, and importantly, we go through logistics. In the United States, the cost of CAR T-cell infusion alone is $500,000, so it's important to get insurance approval before proceeding with this treatment. So once we see the patient in the clinic, if the patient is a candidate for CAR T-cell therapy, the next step is to proceed with apheresis. So in our setting, currently the time between the first visit in the clinic and apheresis is about 7 to 10 days, so we've come a long way. So once the patient comes for apheresis, we collect the T cells. They are shipped for ex vivo CAR T-cell manufacturing. That typically takes about 4 to 6 weeks. Then the patient continues the myeloma therapy. That's what we call bridging chemotherapy. Once the CAR T cells are manufactured and shipped back to the center, we proceed with lymphodepleting chemotherapy or LD chemotherapy, which is usually fludarabine and Cytoxan given over 3 consecutive days, followed by CAR T-cell infusion, and the patient is subsequently monitored for short and long-term complications. So this slide here shows the current US FDA-approved BCMA CAR T-cell therapy that we have available. ide-cel and cilta-cel was approved somewhere between 2021 and 22 for use in later lines. In 2024, following the positive results of the pivotal clinical trials in the earlier lines, we do have these products available for use in the earlier lines. I want to briefly go over the early and late complications because some of these will be managed as an outpatient when we transition to outpatient CAR T-cell therapy. The early complications include cytokine release syndrome or CRS, immune effector cell-associated neurotoxicity syndrome or ICANS, cytopenias, infections, and rarely complications like HLH-like syndrome. In general, the early complications are most exclusively managed by the CAR T-cell center. Then we do have late complications such as hypogammaglobulinemia, infections, neurological toxicity, cardiac toxicity, secondary malignancies, etc. And these are co-managed by the CAR T-cell center and our partners in the community. I also want to take this opportunity to go over the CRS and ICANS profile of cilta-cel and ide-cel, the 2 FDA-approved products that we have. This is important because we'll be managing some of this as an outpatient when we do outpatient CAR T. So as shown on the slide here, majority of the patients treated with these products do develop CRS. Fortunately, most of them are grade 1, 2. The median time to onset of CRS is also different across these products. We have early CRS with ide-cel at a median of 1 day after infusion, and late CRS with cilta-cel at a median of 7 to 8 days after the infusion. ICANS is seen in roughly 20% of patients. Again, it's mostly grade 1 and 2, particularly with use of these products in the earlier lines. Again, same theme here. Early ICANS with ide-cel at a median of 2 to 3 days, and late ICANS with cilta-cel at a median of 8 to 9.5 days. Before I go into the outpatient model for CAR T administration, I also want to introduce the Myeloma Institute of Research, or the MEERA supportive care model. So the MEERA supportive care model is a highly integrated, multidisciplinary model where outpatient chemotherapy is administered, followed by a coordinated care where symptoms and toxicity is managed, all in an outpatient setting. So the idea of the MEERA supportive care model is to administer treatment as an outpatient improve patients' quality of life through robust supportive care measures. Indeed, the Myeloma Institute in Arkansas performed the first all-outpatient autologous stem cell transplantation for myeloma in the world in 1991. So now in the United States, there are several terrestrial centers now administer transplants as an outpatient. So we do have infrastructure in place, and they could easily be adapted to now deliver novel immunotherapy, bispecifics, and CAR in an outpatient setting, keeping in mind that the side effect profile is quite different from transplant. So why move CAR T-cell therapy to an outpatient setting? With outpatient administration of CAR T-cell therapy, we make better use of our healthcare resources, ensuring long-term financial sustainability and scalability. We know that myeloma is a disease of our older adults, so by potentially doing outpatient CAR T-cell therapy, we may improve patient outcome by preventing hospital-related muscle weakness. As we discussed before, majority of the CRS and ICANS are low-grade, particularly with use in the earlier lines. Additionally, with the approval in the earlier lines, we are administering CAR T-cell therapy in the setting of lesser disease burden and to fitter patients. So these are all important reasons to consider outpatient CAR T-cell therapy. Now coming to what are the possible risks when we do outpatient CAR T-cell therapy. We are all aware of rare but potentially life-threatening complications with CAR T-cell therapy, such as tumor lysis syndrome, high-grade CRS, ICANS, neutropenic fever, HLH-like syndrome, etc. With an outpatient CAR T-cell therapy, some of the burden of care is transferred to the patient and the caregiver. So the patient will have to lodge close to the hospital. They have to make 2 and 4 visits back to the clinic. They should also ideally have a caregiver who's available 24/7 and should also have a way of transportation back and forth, because currently, after CAR T-cell therapy, our patients cannot drive for at least 2 weeks. We know that in the outpatient setting, monitoring may not be as comprehensive as in an inpatient setting, and there could be potential admission delays. Patient selection for outpatient CAR T-cell therapy. So beyond the ECOG performance status and the organ function, a patient who is a candidate for outpatient CAR T-cell therapy should be reliable, should have a reliable caregiver who is available 24/7 for at least 30 days after infusion. They should also have the ability to stay close to the center for about 30 days post-infusion. And ideally, we don't want the patients to have highly symptomatic, uncontrolled myeloma going into outpatient CAR T-cell therapy. I want to briefly go over the infrastructure requirement for a successful outpatient CAR T-cell program. The logistics include the availability of temporary accommodation close to the infusion center at the hospital for about 4 weeks. Ideally, there should be some assistance with transportation, keeping in mind that the patients cannot drive for at least 2 weeks after CAR T-cell infusion. The hospital infrastructure include the facility to assess the patient 24/7, the resources to manage early complications like CRS, ICANS, and the ability to escalate and de-escalate care as appropriate. There's a lot of interest in monitoring devices such as wearable devices to enhance patient monitoring safety and experience. The foundation to outpatient CAR T-cell program is obviously our trained personnel, which includes a multidisciplinary team of physicians, physician assistants, nurse practitioner, transplant nursing staff, pharmacists, both in the inpatient and outpatient setting. So this is actually the CAR T-cell team. So the first point of contact when a patient is seen at the clinic is the CAR T coordinator. They help coordinate care, work on logistics, work on patient education. Then we have the multidisciplinary clinical team that consists of the physician, nurse practitioner, nursing team, etc. They are involved in patient selection, patient education, administration of treatment, management of toxicity, symptoms, etc. And the center of the team is obviously the patient and the family. I want to go over the models of care for CAR T-cell therapy. So there's a total outpatient model, where LD chemotherapy and infusion is done as an outpatient, and the patient continues as an outpatient with admission as needed for complications. And this is the model that we have at our center. And then we have the hybrid model of an outpatient/inpatient setup where LD chemotherapy and infusion is planned as an outpatient, followed by planned admission for that high-risk period. And then there is an early discharge model where the patient gets LD chemotherapy, infusion in the hospital, followed by inpatient stay for that high-risk period and early discharge. I want to briefly go over our all-outpatient model for CAR T-cell therapy. So some of the features that I want to highlight here is that our patients are seen every single day, including the weekends and holidays, at the Cancer Center Day Hospital for the first 14 days after CAR T-cell infusion. After the initial period, we transition to twice weekly visits through day 30 in the general hematology outpatient clinic. We don't use any remote monitoring devices. We rely on old-fashioned phone calls and triaging, and that's worked well for us. We do administer LD chemotherapy and CAR T-cell infusion at our day hospital, and the patients are evaluated every single day by the clinical team. Our hospital also uniquely houses a 24-hour clinic that's open and available for after-hour patient concerns. Importantly, our Cancer Center Day Hospital and the 24-hour clinic can administer outpatient chemotherapy, outpatient antibiotics, transfusions, tocilizumab, et cetera, and we are open through weekends and holidays. So I also want to go over some of the caregiver factors when we select patients for outpatient CAR T-cell therapy. So beyond the patient factors, the patient should also have a caregiver who is reliable, who's available 24/7 for about 4 weeks or 30 days after infusion. They should ideally have the ability to read, write, and operate a smartphone or a tablet device. They should ideally be able to also act as a designated driver, that because the patient cannot be driving for at least 2 weeks after infusion. And the caregiver should be able to identify any potential red flags and be able to freely communicate with the clinical team. So the calendar here is actually a real-world experience of how we plan outpatient CAR T-cell therapy. So here, the vein-to-vein time is about 41 days. So as shown here, once a patient proceeds with apheresis, we resume the myeloma therapy. And then in between, they do come back to the treatment center for staging workup. That includes the standard PET-CT, bone marrow, myeloma labs, along with EKG, echocardiogram, pulmonary function test in anticipation for CAR T-cell therapy. So once the cells are shipped back to the center, we promptly start on lymphodepleting chemotherapy. That's actually 3 days of Cytoxan and fludarabine. There's a day of rest afterwards. And on the day of rest, the patient does not come to the hospital. They stay close to the center. And then the subsequent day, they come for the CAR T-cell infusion, followed by daily visits for about 14 days. And we also try to provide the patient with a tentative date where they can potentially go home if medically stable. And this is a calendar that we make for every single patient, whether it's outpatient or inpatient CAR T. I want to go over our algorithm for outpatient management of CRS and ICANS. So during the daily visits, the patient has a thorough physical examination. We look for red flags such as changes in the mental status, hypoxia, hypotension, fever, abnormal laboratory studies, etc. If there are no red flags, the patient continues their treatment as an outpatient. If there are any red flags, the patient's care is escalated to an inpatient setting. So let's say a patient calls in with fever after hours. They call our triage line. They are then promptly seen at the 24-hour clinic. So fever is often a manifestation of infection or even CRS in the setting of CAR T-cell therapy. So all patients who present with fever are started on broad-spectrum antibiotics after obtaining blood cultures, etc. So depending upon the temporality of these symptoms in relationship to CAR T-cell infusion, CRS is obviously one of the important differential diagnoses. So if CRS is suspected, we administer tocilizumab at the first sign of fever, even for grade 1 CRS. The patients are then monitored for 8 hours after tocilizumab. If there is complete resolution of the fever and all the symptoms, they continue the rest of their treatment as an outpatient. If there are any red flags at this point, we escalate the care to inpatient setting. So I want to highlight the key features here. We have the ability to triage and evaluate the patient without any delay. There's access to trained personnel 24/7, early tocilizumab at the first sign of CRS, and the ability to escalate and de-escalate care depending upon the clinical status. So this is our experience that we published in Blood Advances in 2024. So this is the first 58 patients who got outpatient CAR T-cell therapy, and again, 34 patients had a diagnosis of multiple myeloma. In this experience, nearly 60% of patients were able to get tocilizumab as an outpatient for grade 1-2 CRS. About half of the patients did require admission for CRS after the outpatient tocilizumab. If you look at the bottom of the slide, they do describe the admission rates per disease diagnosis, and we see here that about a third of our patients with multiple myeloma was able to continue the treatment entirely as an outpatient without any inpatient care during the entire CAR-T journey. About 28% of our patients were admitted within the first 3 days and 17% within 4 to 7 days. So when we compare this with lymphoma, about 12% of the patients with lymphoma were able to complete their treatment in an all-outpatient setting. But this could also be explained by the difference in the the treatment, etc. So this study really establishes the feasibility of an all-outpatient CAR T-cell program. So how can we improve on this? There's a lot of interest in remote monitoring technologies such as wearable devices to facilitate outpatient CAR T-cell therapy. The FDA-approved wearable devices currently can monitor pulse rate, oxygen saturation, respiratory rate, temperature, etc. And this is actually early experience from a pilot study from Mount Sinai where they used wearable devices in patients treated with BCMA CAR T-cell therapy. In this study, they showed that wearable devices can in fact detect cytokine release syndrome at a median of 3 hours earlier than standard of care nursing assessment. So this is something that needs further investigation and could potentially make outpatient CAR T-cell therapy better for our patients. The slide here shows some of the strategies that we could potentially employ to prevent severe CRS and neurotoxicity. Fractionated CAR T dosing is done in the setting of lymphoma. CRS prophylaxis with tocilizumab, dexamethasone, and anakinra is another strategy. In fact, in patients treated with bispecific antibody, tocilizumab prophylaxis has been increasingly employed, particularly when we try to do bispecific as an outpatient. Early intervention during low-grade CRS. So at our center, we do employ this strategy where patients get tocilizumab for even grade 1 CRS. And that has really enabled us to do this safely as an outpatient. BTK inhibitors and JAK inhibitors are also being investigated as prophylactic strategies to prevent high-grade CRS and neurotoxicity. I want to briefly go over dexamethasone prophylaxis in patients with lymphocytosis following BCMA CAR T-cell therapy. So this is a busy slide, but these are actually 2 independent studies coming out of the Mayo Clinic and the Sarah Cannon Research Institute, where they showed that in patients who receive BCMA CAR T-cell therapy, lymphocytosis could be predictive of high-grade CRS, ICANS, and potentially delayed neurotoxicity such as nerve palsies and Parkinson's. To this extent, dexamethasone prophylaxis was actually used in the Sarah Cannon Research Institute experience, where they used dexamethasone 10 milligrams day 1 TID, 10 milligrams BID on day 2, and 10 milligrams once on day 3. So the short course of dexamethasone was preferentially used in patients who had a lymphocyte count of more than 5,000. And this really needs to be further investigated and ideally tested in a prospective setting. Now I want to go over a couple of real-world experiences. So this is a 76-year-old patient of mine who got cilta-cel as an outpatient. He had an excellent performance status, minimal medical comorbidity. His wife was his caregiver, and he stayed close to the medical center. He went to receive cilta-cel with myeloma in partial remission, secondary to talquetamab therapy that was used as bridging. So he got his LD chemotherapy and CAR-T infusion in the outpatient clinic. Day 5 post-CAR T-cell infusion, he developed grade 1 CRS. He was promptly seen at a 24-hour clinic. Tocilizumab was administered. He had complete resolution of symptoms and continued his care as an outpatient. The patient was seen every single day through day 14. And day 16 post-CAR T-cell infusion, he got a dose of G-CSF for pancytopenia, and he was able to discharge home with weekly follow-up as early as 3 weeks after CAR T-cell infusion. So the key points here is a patient with an excellent performance status, reliable caregiver, and minimal medical comorbidity. He had grade 1 CRS that responded to early tocilizumab, had an uncomplicated CAR T-cell course. I also want to share another experience where things did not go as planned. So this is a 71-year-old patient of mine, had a decent performance status. He had a reliable caregiver, minimal medical comorbidity that included atrial fibrillation and hypertension. He had early disease relapse within 18 months of an autologous stem cell transplant, and he proceeded with standard of care cilta-cel with disease progression. In fact, in this experience, the vein-to-vein time was shorter at 37 days compared to the 71 days in the real-world experience. The clinical course was as follows. He did get LD chemotherapy and infusion as an outpatient. Day +7, actually the patient was electively admitted for feeling of impending doom. He had grade 1 CRS in the hospital and did receive tocilizumab. However, 24 hours later, he had persistent fever and was given a second dose of tocilizumab and dexamethasone. The patient developed AFib and hypotension and was transferred to the intensive care unit. Unfortunately, the patient had doubling of ferritin concerning for early CAR-associated HLH. The patient was started on Cytoxan and Anakinra. However, he went on to develop multi-organ failure with DIC, renal failure with on hemodialysis, respiratory failure requiring ventilatory support, and unfortunately, he passed away due to complications of CAR T-cell therapy. So this is an experience where we started off as an outpatient, we escalated the care to inpatient setting, but unfortunately, the patient had complications of CAR T-cell therapy. In conclusion, outpatient CAR T-cell therapy is essential to improve patient experience and healthcare outcomes as indications expand. With the right team and infrastructure, an all-outpatient CAR T-cell program is feasible and it possibly is an effective approach. Patient selection is key, identifying complications without delay, and escalating and de-escalating care is vital to outpatient CAR T-cell therapy. Thank you for your attention.
Thank you very much, Professor Mohan. Dear friends, dear colleagues, we were witness of a wonderful approach of using CAR T-cell in outpatient manner with this exemplification of a new physician-patient relationship. Patient became not passive, but active part of our therapeutic procedure. So, chapeau bas that you are taking care about the patient in this manner. I know it's not easy. Most of your patients were relapsed on the resistant multiple myeloma. Most of them were of my age, let's say over 70. And I think that, let's say 10 years ago when we started CAR T-cell, we never could imagine that we could use in outpatient manner. But this is probably possible thanks to better and better control of possible complication of CAR T-cell, and thanks to our colleagues who did this job before us. Okay, this presentation is open for discussion. Yes, Professor Sacha.
Thank you very much for your lecture. How many patients did receive the CAR T?
So in our setting, all standard of care or commercial CAR T is by default an outpatient CAR T. So I can say that currently we do around 100 plus CAR a year. So about 90% of these patients, they start off as an outpatient currently.
And technical question, what are your triggers for hospital stay for those patients? And the second, what is the maximal distance of lodging for this patient?
That's a great
for you?
question. So, so the trigger is, it depends on the patient and family too, right? And obviously clinical indications as well. So let's say a patient is admitted following cilta-cel for CRS, right? It's around the time they get admitted, that's day plus 7, 8, they're also neutropenic. So we do manage CRS in the hospital, just like we do outpatient. They get TOSI, they get monitored and all that. But then we want to make sure we're not missing neutropenic fever. So an average is about 5 days if it's uncomplicated. So they get TOSI, they are monitored, CRS subsides, we make sure the blood cultures are negative. It's really not neutropenic sepsis. So then we kind of transition to outpatient setup.
Any stage of CRS or ICANS?
So if there are no symptoms, we kind of discharge them. But then even when they're discharged, they're seen every single day. So we have the ability to escalate care as well. And we want our patients to stay within 45 minutes of drivable distance from the center. We also stay in a place where it snows, so I encourage our patients to stay a little bit closer, if they can, so especially in the winter.
Yeah, thank you very much.
Any other question?
I have a question regarding your experience. It's beautiful results, and do you are alone in the United States? You are doing this, or you have any other centers?
I think increasingly other centers have been doing outpatient CAR T-cell. I know the Mayo Clinic has a hybrid model where they do part of the treatment as an outpatient. They do LD chemotherapy and infusion, I think, as an outpatient, and then their patients are admitted for that high-risk period. Okay. I know that in Wisconsin, our community partners have started doing bispecific as an outpatient too. So they do dexamethasone for low-grade CRS instead of TOSI, but they've been able to do it even in the community setting for bispecifics.
And the second question regarding bridging therapy, you are doing talquetamab only or other possibilities?
So currently, with use in the earlier lines, I rarely use talquetamab or any other, because we have CAR T-cell available as early as the second line. So, and we are able to get our patients to, CAR T-cell therapy in a very short time, unlike when we started, the wait time was 3 months and all that. But we've got to a state where we could get a patient to CAR T-cell therapy within 4 to 6 weeks. So I don't feel like there's really a need to use talquetamab if we are using it in the early line plant. But obviously in the late lines, this gentleman that I've used talquetamab, he presented actually with secondary, there was some circulating plasma cells. He already had all kind of therapies before, and that was the only thing that I could use.
Thank you.
Thank you very much. We have to...
Yes.
Sorry. We have to continue our...
Sorry, I have a question. MEERA,
one question.
One question to this discussion. Thank you for a very impressive lecture. But the question which bothering me, based on your experience on the question of Arthur about therapy followed by CAR T, what is your opinion about efficiency in patients who received anti-BCMA T-cell engagers before CAR T, also anti-BCMA?
So obviously the efficacy
because there's some group of patients who receive before CAR T treatment before progression anti-BCMA, for example, teclistamab, yeah. And what is your basic experience, high experience? What is efficiency of this CAR T treatment?
So that's a great question. So typically, if we do a BCMA bispecific, we know that with bispecific, you tend to have higher rates of antigen loss, right? Because it's like 40%. So unlike CAR, post-CAR, the BCMA antigen loss is like less than 5%. So, but we do have patients that have received bispecific before CAR T. The efficacy is kind of lower than what we see in the naive, like BCMA naive setting. Yeah. But then what we try to do is we make sure that there's an adequate time between the therapy, at least 6 months to a year if we can. So I try to use other treatment in between and then do a planned CAR T if we can. Yeah. But in an ideal setting, I would do CAR before bispecific if I can.
Yeah. So, and have you got an experience with T-cell engagers after CAR T treatment?
Yeah. So we have quite a number of patients who receive bispecific after a CAR T. So again, if the patient have had a good response to CAR T cell therapy, somewhere a year or so, then they do okay with bispecific. But if they have a rapid relapse following CAR T cell therapy, I think bispecifics will likely not work.
But in many cases, lymphomas is just effective T-cell engagers after CAR T treatment. So because in Poland, your lecture is like a dream for us, because we're still waiting for reimbursed CAR T treatment in multiple myeloma indication. We have experience in CAR T in lymphomas, but outpatients treatment with CAR T therapy is completely impressive. I would like to visit in Wisconsin and see it. Thank you.
You're welcome in Wisconsin.
Thank you very much. And I would like to ask my co-chairman to introduce next speaker before that Artur has some
Next
remarks.
speaker is unfortunately not here because this is Professor Kumar, Lalit Kumar. We tried to arrange him visa from India, but it's not so easy at the moment. You probably heard these troubles with visa, and sent 2 letters to Polish embassy, and it was no response. So we have contact with Lalit Kumar by online, and his lecture is here.
Good morning. This is Dr. Lalit Kumar from India. Thank you, Dr. Artur, for inviting me to this most important and very prestigious 13th International Conference on Complex Treatment of Plasma Cell Dyscrasias. What I plan to do here is to share some of the glimpse of our experience of treating multiple myeloma over past 2 decades, which will give you some idea how we treat multiple myeloma in India. Data which I am presenting here today is from my earlier institute, All India Institute of Medical Sciences, where I worked for nearly 38 years till very recently when I superannuated. In multiple myeloma, we have the classical presentation in the form of bone marrow plasma cells, serum protein electrophoresis, and skeletal survey. Some of the clinical features which we have compared between our data from the Mayo Clinic data, in almost nearly 1,500 patients, what we found that the median age for myeloma in India is almost 56 years, which is 1 decade earlier compared to the Caucasian population. And nearly 8% of patients do have myeloma at the age of 40 years or earlier. Myeloma isotype is almost similar. The median hemoglobin is slightly, the anemia is slightly more in our population, and albumin levels less than 3 grams per deciliter were nearly seen in the 1/4 of patients. Similarly, serum creatinine more than 2 milligrams was seen in nearly 1/4 of the patients. However, the beta-2 microglobulin was significantly higher. Nearly 40% of them did have more than 6 milligrams per deciliter. We also analyzed data on the fish to see for high-risk cytogenetics. In almost 1/4 of patients, we found that there was high-risk cytogenetics, which primarily involved deletion 17p, 414, and 14/16 translocation. For induction therapy, we have generally preferred the VRD regime, but it has evolved from the doublet to various triplets. And in the last 3-4 years, we have started using daratumumab along with these triplets, though the routine use for the first-line therapy is still very, very limited. We have analyzed the experience of induction therapy and the response rate over the past 2 decades for this presentation. And what you can see it as it has evolved, the alkylating agents, the response rate was nearly 50%, which improved to nearly 70% with the VAD, that is the vincristine, adriamycin, dexamethasone, which were used till 2001 or 2 as a continuous infusion. Subsequently, when the novel agents became available, initially with the doublets, the response rate was nearly close to 80%, which improved to further nearly 90 to 95% as we have used the various triplets. We have also done some randomized trials to evaluate what is the best induction therapy. When we compared the doublets, both lenalidomide and dexamethasone, with earlier thalidomide and dexamethasone, we found nearly close to 70% response rate. And when we compared this len-dexa with the triplet VRD regime, we found the complete response rate was slightly more similar, both in the doublet and triplet, and the both complete and partial VGPR and partial response rate was also nearly almost similar. When we compared the VRD regime with the VCD, that is the bortezomib, cyclophosphamide, dexamethasone, the complete response rate and stringent CR rate was superior with the BRD protocol compared to the VCD. However, when we combined both CR, VGPR, and partial response, they were nearly similar with both the regimes. Coming to the autologous stem cell transplant, as it has been practiced throughout the world, the patients who were eligible for transplant, we have taken them for stem cell high-dose chemotherapy with melphalan, followed by autologous stem cell transplant. And we have used various regimes since these patients have received either doublet in the initial years, followed by triplet in the last almost 15 years. And the response rate has varied from 35% complete response and very good partial response, nearly 25%. The overall nearly close to nearly 95%. When we compared these, the induction response rate was superior with triplets compared to doublets. Stem cell mobilization was also superior with the triplet compared to the doublets, both thal and len-dexa. And the day 100 transplant-related mortality, which was 3%, was higher in the doublet regime. However, the transplant response, that is on the day plus 100, the complete response rate to transplant, the median overall survival, as well as the median PFS, progression-free survival, was similar, both whether we have used doublet or triplet as an induction therapy prior to transplant. For transplant, we have used the various steps, mobilization of stem cells by the GCSF for 5 days. Rarely, only few patients have received chemotherapy in the initial days before the plerixafor became available. And this was followed by high-dose chemotherapy, 200 mg per meter square melphalan, followed 24 hours later with stem cell infusion. And subsequently, response to transplant assessment at the day plus 100, followed by maintenance therapy. We have used in the past nearly almost a decade the policy of assessing the CD34 count on day plus 4 and the peripheral blood. If the peripheral blood CD34 count is less than 20 per microliter, then we normally give them plerixafor, which helps them to mobilize the stem cells adequately and reduce the number of stem cell harvest. These are some of the cartoons of stem cell harvest in progress, and this is how the blood counts fluctuates in the post-transplant period. This gives you summarizes our experience over the past 2 decades. In initial years, the complete response rate was just 36%, but over the years, when we have primarily the novel agents being used, the complete response rate to transplant has gone to 68%. And including with VGPR and partial response, this is nearly 85%. And we also looked up the impact of time to transplant, and those patients who have undergone transplant within 1 year of diagnosis, there the overall survival as well as the progression-free survival both were superior compared to those who received transplant after more than 12 months. Also, we analyzed the data and published recently the impact of the dose of melphalan on the various parameters. And what we found, the patients who received 140 milligram per meter square melphalan because of renal impairment or major comorbidities, their outcome in terms of overall survival as well as progression-free survival was similar in both the arms. Following transplant, we assessed minimal residual disease on day plus 100, and we used both flow cytometry as well as the PET-CT scan. And what we found, interestingly, the patients who are negative by both, MRD negative, measurable residual disease on day plus 100, negative both for by flow cytometry, which was 10 raised to 5 minus 5 sensitivity, and recent year it has gone to 10 raised to minus 6 the sensitivity. And we found that patients who had both negative by both flow negative as well as the PET negative, they had significantly superior outcome compared to those who were the flow positive, PET negative, or both being positive. So we believe that the composite assessment of transplant response by flow and PET scan is always superior than the either alone. And the negativity by both is probably the best parameter to predict the long-term outcome. Interestingly, we also have analyzed very recently the long-term outcome following transplant. And what we defined the patients who have actual survival of 120 months, that is 10 years or longer, we call them long-term survival, LTS group, that is the group 2. And we compared that by 96 patients out of 438, which is nearly 22%. Compared this data with the patients, 55 patients who succumbed within 2 years of transplant, and another group, that is group 3, which was intermediate, that is more than 24 months and less than 10 years. So we compared the data and we found that the progression-free survival was superior, nearly in the tune of almost 13 years for the LTS group, long-term survival group, compared to the either early relapse or the intermediate group. Similarly, the response rate, the CR and complete response, very good partial response, or combined was superior for the long-term survival group. Similarly, we found for patients who were long-term survival group, the median overall survival for this particular group is nearly 22 years. And again, their CR, complete response, very good partial response, individually as well as combined is superior compared to the either group. So this is very depicted in this particular figures. The top line is basically for the long-term survivor. The red line is for the intermediate group, and the green line is for the early relapse group, both in terms of overall as well as the progression-free survival. However, there have been inequities in the management of myeloma throughout the country. For example, some of the investigations like serum free light chain assay, FDG PET scan, and the cytogenetics or the FIS assessment is not available at all centers in the country. It is still limited to the major teaching hospital or corporate hospitals. The transplant facilities are still limited largely to the major teaching hospitals, and there is still limited access to the drugs for relapse and refractory disease, like carfilzomib, which has now become available, but the isozomib and some of the monoclonal antibodies, bispecific antibodies, and CAR T-cell therapy is still very, very limited. And it's just beginning to be becoming available. And hopefully in next 5 years, some of these limitations probably would be overcome. We just want, before ending this, I like to give you some of the data, how we have really treated them for the relapse. We analyzed the data of 193 patients who have 82 of them had the biochemical relapse. That means they were asymptomatic but qualified as per the IMWG criteria for the relapse. They were called the biochemical relapse or asymptomatic relapse. However, the remaining 111 patients had the clinical relapse, and there we compared their outcome at the median follow-up 30 months. There were really no difference in the outcome. The other important finding we found that patients who achieved complete response following the salvage therapy, they had a significantly superior survival compared to those who did not achieve complete response. This paper has been accepted very recently in the Clinical Lymphoma, Myeloma and Leukemia Journal. And we also looked up the various lines of therapy after the salvage therapy. As you can see from this Sankey plot, that they have received the various available, whatever was available, the lines of therapy for the subsequent management, third line or fourth line relapse management. Daratumumab, we have some experience as a phase 4 trial, and as a single agent we used for the relapse and refractory disease, mainly the refractory patients. And what we found that in nearly almost 26% of patients did achieve complete or very good partial or partial response with the single agent response rate. In another 60%, there was stabilization of the disease. However, nearly 10% of patients did have progressive disease while on daratumumab, but this is for the relapse and refractory disease. So to summarize, we have evidence that there is a rising incidence of multiple myeloma in our country, in India. This is possibly due to the rapid industrialization which is taking place. We have shown you that the biology of myeloma, at least clinical parameters, laboratory parameters, and based on the FIS, appears to be similar compared to the Caucasian population. The response rate are similar if you are using the standard induction therapy and standard autologous stem cell transplant. And in our population, we found post-transplant long-term survivors of nearly 22%. So with this, I like to acknowledge my colleagues in the department, the AIMS myeloma group from various departments, and residents, nurses and lab staff, patients and their families, and some of the government funding agencies who helped to do some of these studies which I presented before you. Thank you so much, and my sincere apologies that I'm not been able to be present physically in front of you. But I look forward that maybe next year I would certainly make sure that I'm there to meet all of you. Thank you so much.
Possibility to ask questions. Yes, because it was recorded before. If you have any comments regarding this presentation, welcome. As we understand...
I have one comment, if possible. LALIT showed that progression-free survival regarding MEL 140 over MEL 200 is similar. Do you agree with such results or any other ideas? Because in my experience, 200 is absolutely the standard of care, and it's much better, and progression-free survival, as you agree, it's longer. And I'm a little surprised regarding this result. So this is short comment. Yeah, of course. Yeah, please. Michael.
While this isn't exactly my area of expertise, I think it does illustrate the importance of, studying different patient populations, and the importance of including people of different ethnicities in clinical trials, because we cannot assume that necessarily that the pharmacokinetics that apply within a Northern European sort of Caucasian population necessarily apply to other populations. And so while 200 milligrams per meter squared of melphalan may be what you or I should have if we're being treated with high-dose therapy for myeloma, perhaps that might end up being too much in some cases in other ethnicities. So I'm not familiar with the PK data around melphalan, but I am certainly aware in other drugs of how particular populations can be much more susceptible and have different pharmacokinetics with different agents. So it may be something just to keep in mind.
Thank you.
Thank you. If we have any other comments.
Yes, maybe I have one comment. In currently, when we have access to such advanced treatment like CAR T-cell, T-cell immunotherapy, this research shows that efficiency of 114 versus 200 milligram of melphalan, in my opinion, exposing patient for higher dose of melphalan currently is not necessary, because we have a wide field of treatment possibility next line. It was very important, for example, tandem autologous transplantation in the past, when we haven't narrow landscape of treatment. I think personally that autologous transplantation in few next year went to history. Thank you.
Thank you. I think it is a very good introduction to the next speaker. So it is great honor to welcome the Professor RAFAEL FONSECA from Mayo Clinic, who told us the lecture entitled Impact of the Disease Progression, Line of Therapy and Response on a Health-Related Quality of Life in Multiple Myeloma. Please, Professor.
Well, thank you very much, and thank you, Arthur, for the invitation. I think MEERA said this is a memorable meeting, and we're so happy that you invited us here. I've been particularly thrilled with Poland and the Polish people. Everyone seems so happy you have a prosperous nation, so it's really wonderful to be here. At the same time, yesterday we had the opportunity to visit Auschwitz, and it's a reminder, of course, of what happens when human efforts are put against humanity and existence, as opposed to what we do in medicine. And we're all here together, of course, trying to make the lives of humans better. And we heard numbers like hundreds of thousands and millions as we were doing our visit in Auschwitz-Birkenau. So I looked up and I thought, myeloma is diagnosed in about 150,000 people per year globally. And there's significant improvements in survival. And by some estimates, I would say with patients having best possible access, you can expect a life expectancy of at least 12 years, when it was 2 years when I finished training. So that's 10 years gain. So that means for every year, all this progress that has occurred in myeloma saves 1.5 million life years for humans. So I think it's a tremendous moment to be proud of that. And then we're just one of many other cancers. So we're seeing tremendous progress. And the second point is, it is because of meetings like this that we can have this exchange that we're seeing the progress. And the progress never happens fast enough. Of course, we want people to have access to the medications very early. But we heard from Dr. Kumar. RVD is being used quite frequently in their patients. And 5 years ago, many people would say RVD is out of the question for many Indian patients. And the same will be said about CAR-T and daratumumab and bispecifics and everything else. So we all have to keep together and press for this progress, because as I will show you, I think there's demonstrable benefit for patients. So it's an honor again to be part of the team that has done this. These are my relationships with the private sector. So as an example of this improvement in survival, I'm going to show you 3 series which show the treatment of patients with what today, in 2025, we wouldn't think this is the best, but it's still very good. So these are patients who get transplant and get lenalidomide maintenance. Some of them got RVD, some of them even got CyBorD. And as you can see there, the survival is greatly improved and should be exceeding, as I said, 10 years. We have seen great progress. On the left is when I was doing training with Professor Kyle, who sends a beautiful letter for the introduction of the booklet, where the median survival, overall survival for myeloma patients was barely over 2 years. So we've made tremendous progress. But we do know that many of our patients still relapse. And this relapse, of course, every time leads to a shorter duration of the control of the disease that we have. And this is just one such example using real-world evidence where you see by first, second, and third line and so forth, the duration of the disease control gets shorter. Now, I think there's a growing movement within the myeloma community, and I'm pretty vocal about this, that we can cure some myeloma patients. I do believe firmly we're curing already some patients. So these are 2 cases which are anecdotal, but there's larger series that have been published, but I just want to show you. On the left side is a patient of mine who was treated with thalidomide and dexamethasone 20 years ago, had a single stem cell transplant, and has not had a shred of disease 20 years later. It's hard to argue this person is not cured. Well, on the right side is another patient of mine where we're now routinely using MRD testing in the bone marrow at the sensitivity of 10 to the minus 6 with clonoSEQ. And as you can see, this person has been MRD negative consistently for 6 years. Is he cured? I can't tell him that yet, but it's looking pretty good. And I think there's a significant fraction of patients like this who will be cured. But the best opportunity to achieve that is in the very first line of therapy. Now, being a place where there's Copernicus, I had to bring something different. So this is Fibonacci from the 13th century. And Fibonacci, as you know, showed us a progression of the Fibonacci number. And I say that the myeloma therapies until recently were the inverse of Fibonacci. So you quickly went from 21 being first line to 13, 8, 5, and so forth being the successive lines of therapy. However, the principle still stands that the very best opportunity we have for the best treatment of myeloma remains in that frontline therapy. And here's one such example. This study by Dr. Mateos, the locomotion clinical trial, shows what happens when you try some of the drugs that we have traditionally used, what I call now control drugs. You have a response rate under 30%. So yes, some patients can respond, and we're happy for that, but 70% of them won't respond. So we needed better therapies, and you've heard from Dr. Mohan, of course, of the use of novel therapeutics like CAR-T, which again, I know they're not widely available, but they will become a reality for myeloma patients. Now, a second concept that relates to the title that Arthur asked me to discuss is lines of therapy and the impact on progression. And one of the factors that is so important, and it's in myeloma, and I bet you I haven't studied this in detail, it's in other cancers, is the rate of attrition. With every line of therapy, there's a fraction of patients that cannot advance to the subsequent line of therapy. This is the first study published by Dr. Young in 2016, where they looked at 1,800 patients who started on lines of therapy, and as you can see, it kind of starts dwindling down. Less and less patients can advance. Now, sometimes patients do very good, but there's disease progression, complications, and death. And when we think about the long-term strategy of myeloma, you have to take these numbers into account. Now, one of the papers that I've participated on, and has been one of my most cited papers, is this one, which we published in 2020, which brought now real-world evidence to attrition rates, but now we could expand the numbers. So the upper part is not transplant-eligible patients, 22,000 patients. The bottom part is 2,700 patients who are transplant-eligible. And the percent you see on the far right are the fraction of patients that are being lost by lines of therapy. And I say this is so critically important because we have to think about this, we have to think about the loss, And the possibility that assuming I'm going to save a drug for later actually does not necessarily make sense because there may not be a later for that patient. Now, when we first published this, we got some pushback. Maybe the numbers are high. But ever since, there's several other series that have published the same results. These graphs, they call them in English the tornado graphs. For obvious reasons, they have the shape of the tornado. And the percentages vary, but the results are the same. You start losing patients by line of therapy, which relates to the title that they asked me to talk about, lines of therapy and effective progression. Now, one of the very interesting things that has happened, the Spanish group just published this year, which is the attrition rate in a very large Spanish cohort. And this is a basic graph, but I'll show you quickly what it shows. In yellow is the attrition rate. On the left side, you see as time goes by, the attrition rate has dropped. And the reason it has dropped is because the treatments are better tolerated. So if you're going to go from VAD to DSEP, patients are going to say, enough, I don't want to keep going forward. But if you're going with treatments that have better tolerance, like daratumumab, I'll show you some data, then more patients can stay on therapy. However, there's another story that's on the right side of the graph, and that is attrition is particularly high for the elderly. And that makes sense. We see patients in the clinic, more advanced age, frail, they're less likely to want to continue on therapy. Now, one of the comments always one thinks about, well, in myeloma, it's a very expensive disease. It's very expensive to treat myeloma. And I surprise people when I tell them, be grateful for that. The reason it's expensive is because there's innovation. Metastatic pancreatic cancer has not necessarily been expensive. So we have all this innovation. But sometimes this comes in surprising ways. So we published several studies. This is one of them, looking at the burden of disease progression when it comes down to expense for healthcare systems. And what you see this is for transplant ineligible patients, again, using real world evidence. So there's a cluster of columns, they come by two. The first one is without progression, the second one is with progression. First line, second line, third line, and fourth line. And what you can see there is that the healthcare expenditures are higher if patients are progressing, despite the fact that the cost in drug is higher if they're not progressing in general. So yes, you spend on some medications, but then if you don't, then you have to spend on hospital surgeries, transfusions, everything else. So we have to keep that in mind. And this is just one such model. We published this 4 years ago, looking at the same concept of the burden of disease progression. And I won't walk you through all the details, but the bottom line, what you see in orange is progression. So progression is more expensive to health systems than lack of progression. Now, of course, this doesn't take into consideration that lack of progression allows you to go to weddings, to baptisms, and to do all the other things for which we cannot put monetary value. And the same is true, and this is going to be my last slide on this. This is for transplant-eligible patients. Again, everything is clustered in two columns. Progression is expensive. So as we think about all these treatments, we think about the options, there's multiple ways by which we can measure success. Well, how else can we think about the effects of lines of therapy and progression and quality of life? I'm going to show you a couple of examples for that. You're all familiar with the Perseus clinical trial, which has been presented and published now for the newly diagnosed transplant-eligible patients. Now, this is a randomized phase 3 trial that compares VRD to DARA-VRD, transplant, and then consolidation and maintenance, with the maintenance including DARA if you got that up front. Now, as you saw from Dr. Kumar's presentation, VRD should be a worldwide reality now that both of them are generic. And when I travel a lot to Latin America, I tell my colleagues, when the payers tell you, oh, you were always crying for a VRD, there you go, you have it. I says, well, yeah, I need the monoclonal antibody now. I need the CD38 antibody. And why do we need that? Well, first of all, the results are better, much better. The result of the clinical trial met its primary endpoint, the PFS 84.3 at 4 years. Recently, at the European Myeloma Network, which was held in Athens, they project a median PFS for patients treated with a 4-drug of 17 years. That's quite a difference from where we were before. But let me show you some things that we don't necessarily talk a lot about some of these trials. So in general, if you're on another drug, you're going to think that other drug is going to cause more toxicity, so more drugs has more risk of the patient stopping therapy. And that is not always the case. So this is one of my favorite slides from Perseus. So you see there's a reason for why patients discontinue therapy while on treatment. Adverse events, which you see there, is 9.1% for the 4 drugs versus 22.5% for the 3 drugs. That does not make sense. Does that mean that daratumumab protects against some side effects? I seriously doubt it. I think what happens is when we have better treatments that are well tolerated, patients are more likely to be able to want to stay on treatment. And their doctors are more likely to say, you're doing well, let's stay on treatment. So quite a difference, 9.1 versus 22.5. Because then you see progressive disease. There's a big difference, 8.3 versus 20.7. So again, we have to think pretty holistically when we think about quality of life, the cost of progression, and the benefit for the various lines of therapy. To build on this topic, let me tell you about some aspects of MAIA, which I find fascinating. So MAIA is 3 drugs, DRD versus RD, for newly diagnosed myeloma patients. And as you know, this also met the primary endpoint with a significant improvement in progression-free survival. We'll talk more about some of the other studies. But interestingly, MAIA was also associated with improvement in quality of life for patients. This is one of my favorite regimens because of the ability of patients to receive therapy that is highly effective and is perceived as not being detrimental and actually being incremental to their quality of life. Now, talking of that, 5 years ago, I was sitting with you and you were to ask me, I have an 85-year-old patient or an 80-year-old patient where I'm thinking about treating him for myeloma, what would be your answer? So my answer would have been lenalidomide plus dexamethasone. That's what I would want to do, especially if they're frail. But MAIA has shown us differently. So this is one of the most important slides for MAIA. This looks at patients according to their frail status and breaks it by treatment arm. And what you can see is in the top green line here, you see patients who receive their RD that are not frail. Those are the ones that do the best. But they're followed very closely by their RD who are frail, who do better than those that get RD and are not frail. And of course, the group that does worst is patients who get RD and are frail. So in other words, sometimes we may be shortchanging the efficacy of treatment for patients out of what I might call a misunderstood compassion. So if you have effective treatments and they're well tolerated, then obviously we have to think about trying to provide them for patients. And the same is true for dexamethasone on quality of life. And when I talk to my residents and fellows, I use this slide, that I say the treatment of elderly patients is like fishing. I don't know how to fish, but I know experienced fishermen know that you need to have the right tension in that line. If the line is too tense, it snaps and you lose the fish. So if you put high doses of dexamethasone, and the patient now comes to the next appointment, and the family said, my grandma, she had a great life. I don't think we need to go through this. Then they stop therapy and we lose the opportunity. If on the other hand, the line doesn't have tension, it's like the line I just showed you with RD for the treatment of failed patients. So we have to try to find the right tension. I know this is just abstract concept, but obviously you all know that from your clinical practice, that that's how we go along and select effective therapies. We published a study a couple of years ago that we asked ourselves the questions, okay, what is the adherence to daratumumab once patients get established on treatment? And what we meant by that, okay, a patient starts on treatment with daratumumab, and then once they get going and we know it's working, how long will patients be able to stay? And what you see here in months is reflected in the percent of patients can stay on therapy. So adherence to daratumumab as prescribed, once patients reach months 9, 12, and so forth, is close to 96 to 98%, which means patients do very well and tolerate this. So oftentimes when I treat patients with the MAIA regimen and they start on Dara Lendex, and a few months go by, maybe a couple years go by, and we talk about simplifying the treatment, the most frequent comment I get, I would rather stop lenalidomide and come for my monthly injection of daratumumab. Now, my traditional doctor of mine might say, well, that's a pill, that's maintenance, right? The patient say, I don't care. I want to come back here and I want to drive for my injection. Okay, now I'm going to shift gears just briefly to conclude and talk about some of the other aspects that I think is critical for quality of life. And to me, this is probably one of the most important things we need to be paying attention as myeloma doctors, and that is peripheral neuropathy. So we've seen the data with IMROS. This is for patients that are not going to stem cell transplant, isatuximab, another CD38 antibody plus VRD versus VRD. This study, along with CEPHEUS, have established that 4 drug combinations are more efficacious than 3 drug combinations in patients of more advanced age. This study showed clear superiority of isatuximab VRD over VRD with progression-free survival that has exceeded what we have seen with MAIA. But for the first time in my life, I'm thinking we have to be very cautious now here about the incremental effect of the toxicity, in this case, the 4 drug being the proteasome inhibitors. The rate of peripheral neuropathy for the bortezomib treatment was 54% and 60%, 7.2 grade 3 and 4, 6.1 grade 3 or higher for the 3-drug combination. So I'm grateful for the greater efficacy, but this is something we need to keep critically in mind, especially because of patients of more advanced age. Neuropathy will be associated with gait instability, risk of falls, a number of other complications. And I tell my residents and fellows, you know, my least favorite story of treating myeloma is someone telling me, doctor, thank you, you saved my life, but I still cannot feel my feet. And that's really one of the key things for quality of life. Now, obviously, we've seen great improvements with the use of bortezomib, particularly because it's used in a subcutaneous and weekly fashion, and that was a significant improvement. However, we had recently the BENEFIT clinical trial that came from the French study, again, randomized study for the treatment of patients that are not going on to stem cell transplant, this ESA VRD versus VRD. So we can isolate the effect of bortezomib in this particular clinical trial. And now you see the rates of neuropathy, peripheral neuropathy, are 50% with weekly subcutaneous. You see that here on the right side. I think this number, for some reason, seems artificially high. Grade 3 or higher is 27%. But the point is, neuropathy has not gone away. So I'm sort of mulling in my mind, how do I use a 4-drug combination in the more advanced patients, maybe with early termination of bortezomib if we start seeing peripheral neuropathy. But this is an important discussion to have with patients as we think about quality of life. Now, and this is a graph, for this reason, and this is not something I'm a little bit of an outlier, I have in general favored the use of carfilzomib for treatment combinations for myeloma. And I'm going to show you the grades of peripheral neuropathy as we see them. So these are some of the early studies with either just lenalidomide or carfilzomib, and in red you're supposed to see grade 3 and 4 peripheral neuropathy, which we didn't see back in the day. Then you see all of the studies that have used bortezomib do show a significant proportion of this. And here is not to say we should not use bortezomib. My only recommendation is for everyone to pay a lot of attention to this. So I spend a lot of time talking about this, and the same is true for patients. Now, more recently, as we look at other clinical trials that have used carfilzomib, you can still see some peripheral neuropathy, but you rarely, if ever, see grade 3 or 4 with carfilzomib-based combinations. So essentially, what we need to do is we need to find the balance between efficacy and safety, particularly for the more advanced age patients. For the younger patients, I told you at the beginning of the talk, I do think we have the possibility of having very durable responses and actually cure of the diseases for some of those patients. I do think we need to look at the whole problem holistically. I don't think saving in one area necessarily translates into savings globally, as I showed you with the effects of progression. And again, concluding by saying we're in such a fortunate time to be living and seeing what's happening in the field of myeloma. So Arthur, again, thank you very much for the invitation. If people don't remember the electrophoresis, this is how you do it. So thank you.
Thank you, Professor Fonseca, for such interesting lecture. And I'd like to start discussion. Does any question from the audience? Any comments? Yes, please, Professor.
Thank you. Sure.
Did anybody seen any relationship between the gain of the quality of life and the age groups? Is it not possible that the younger people, they have better gain than the older people?
I don't know the answer to that question. That's a great point. Yeah, it's possible that it's going to be different. I think because there's limited decrement for limited added toxicity that is symptomatic. I don't see that, but it's possible that younger might do that, but I really don't know the answer to that question. When I say DARA is well-tolerated, it's with regards to symptoms that arise from the administration. That's not to say there's no risks. The main risk one has to keep in mind is, of course, the increased risk of infection. Every single trial that mixes either daratumumab or isatuximab slightly increases the risk of infection, and particularly pneumonia.
Thank you.
Yeah.
My co-chairman, Paweł Steckiewicz, was a little bit skeptical whether in future we'll be using autologous stem cell transplantation, multi myeloma. I wonder what is your thinking. In my opinion, irrespective to the using 140 or 200, high-dose melphalan is so little toxic and it's so effective, and despite the great scenario of new approaches, I think we could really profit, our patient could profit out of therapy. In our Krakow center, out of 2,000 transplantation, about 500, Artur, am I right, were done in multi-myeloma patient without any toxicity and with great effectiveness. What's your approach to that?
Thank you very much. I'm going to start by putting in my disclosure slide, which the bias, I do believe in stem cell transplant. I think it's a very effective therapy. I think it's very safe. I always say, easier said by the doctor, but it's very safe. It's routine for the medical teams, and it has global access. There's so many countries that have access to stem cell transplant. But even in the context of a country like the United States, I do think today stem cell transplant adds benefit to patients. So if you look at all the quad studies, Cepheus, Benefit, Imbros, et cetera, they reach an MRD negativity of about 50 to 55%. If you look at quads plus transplant, it goes to about 70 to 80%. So there's at least a 15 absolute point percent differences between getting a stem cell transplant or not. Now, it may be that in the future, transplant is replaced by CAR-T or by specifics. And I always say, if transplant goes away, I won't be crying because I don't attend the transplant meetings. I'm not a hardcore transplanter. My focus is myeloma. But today, I still believe transplant provides significant benefit for patients. And so I'm biased in favor of doing transplants. And if I see patients, I try to encourage them. There's a lot of exceptions. I have a patient who has a familial BRCA mutation, so I encourage the person not to go through transplant. Or I have someone who has achieved an MRD negativity after induction and says, I'm a professional, I can't take time away. So we collected stem cells, but if possible, I prefer to move to stem cell transplant. And your question your point was great, Artur, because the pharmacodynamics of melphalan are just all around the board, and I think we understand very little. I don't even know that 140 and 200 is the right way to do it. I know there's people that are working on this. Karen Swice is a pharmacologist in the United States who's looking at measuring metabolism. But anyway, very long answer to the question. I do think stem cell transplant remains an important option, at least today.
I have a question because it's a session about quality of life. It's very important for patients, as you told. And my ask is regarding your opinion about belantamab mafodotin, because at the moment in Europe it was established, but not in the United States. Mm-hmm. What is your comment?
You know, I think when we describe the toxicities of all the drugs, we as doctors, and particularly when we talk to patients, have to try to be as subjective as possible and not minimize, but also not exaggerate. So belantamab in the United States went through a very rocky road because people were saying, oh, patients are going blind. No one goes blind with belantamab. It's usually reversible. Can it be very bothersome? Yes, it can be very bothersome. So we haven't had it in the market, as you know, for some time. But now with what we know of the new schedules, I actually feel very comfortable with restarting belantamab in my clinical practice because of the doses that are used and the spacing out with the doses. So I'm hoping to have that soon again in the United States. I'm jealous that in Europe now it's available again. But I think we need to describe it to patients. But it's important to say it is reversible, for instance. I had some fights on social media where people say, well, patients go legally blind. Well, yes, technically, that means for the time that you're at your worst, you can have that. But most patients will not get there, and in all cases, it is reversible.
Yes, I would like to comment. And Mr. Professor, don't be angry for me, but I stay on my statement because it's referring to your lecture, quality of life. We know that autologous transplantation, it's effective, of course, yes, but it's changing quality of life of patients for many months, yes, and of course, it's efficiency, yes, but this what MEERA doing in Wisconsin is also impressive. It's having a lower impact for a quality of life in opposite to autologous transplantation. So I believe that in the future, this landscape of treatment in multiple myeloma completely change. Also in the field of quality of life patients. Now, like Arthur many times told me, it's incurable disease, multiple myeloma, but it's like hypertension, you know, like diabetes. It's some condition we could treat with managed quality of life. Nicolaus Copernicus, many centuries ago, also believed that the treatment which he had was effective, but landscape completely changed, and it's everywhere it's much better for patient and for what is very important, quality of life, in my opinion, and it's my statement.
Yeah, let me just a quick comment on quality of life on transplant. I agree, and there is no question that doing a stem cell transplant in the short term has significant detriment of quality of life. And what I usually tell patients is going to be 3 months that it's going to take for you to recover, like from a big surgery. And it may not be that they're miserable, but some patients have a lot of problems and they don't eat and they have nausea. But let me change the numbers of what I said for MRD. So MRD difference is about 15% absolute points. And for some people, I say, well, does that matter? When you look at the PFS that is projected now for the CEPHEUS clinical trials, maybe in the range of about 8 to 9 years. And let's assume that Perseus is right at 17 years. So then I would rephrase the question. 3 months of loss of quality of life for a gain of about 9 years of life, is that worth it? To me, the answer is pretty obvious, that I would do it, not being the patient, of course. But so I think we need to balance all of this out and present the options with all that detail to patients.
Yes, but we don't have guarantee that it will be 9 years after 3 months in hospital, for example.
For sure. But there's no warranties in life. That's why we get married and do all these things, right?
So I'd like to prefer outpatient CAR-T treatment than inpatient autologous transplantation. In my opinion, yeah.
You know, if we prove the data to be true, CAR-Ts are simpler than stem cell transplant. And the patients go, oh, this was so much simpler. So if CAR-Ts are proven to be better and are reimbursed, I'd be the first one to jump in CAR-T.
Thank you.
So when we compare non-relapse mortality, right, CAR and transplant, I always tell our patients the chances of a complication leading to death in transplant is 1% in our setting. With CAR, it's 10 to 15%. So at least in my humble opinion, if a patient is not a candidate for transplant, I'll think twice before offering CAR-T to them, although we do a lot of CARs.
Yes, please consider one thing. CAR-T treatment is still developing, yes. With such another new generation, we are looking for more safety. But autologous transplantation, it's have a length story, yes, and it's still the same. So we know this, yes. But I believe that developing of CAR-T, of immunotherapy, generally extremely change treatment landscape. It's my private opinion. Thank you very much. So next.
Thank you.
Artur, have a comment?
No, it's next presentation.
Yes, it's next lecture. I would like to ask my colleague from Greece, Professor ERINI KATODRITOU. This very, very interesting topic is central nervous system multiple myeloma is unfortunately a very serious condition, and managing of this is very challenging. So please give us some interesting practical advice, because it's still a huge problem for us. Please.
So, good afternoon. Thank you for the introduction. First of all, I would like to thank Arthur for the kind invitation. It's a great pleasure for me and honor to be here with you in this historical university and room and in this amazing city of Krakow. So my task is very difficult because I will talk to you about the most devastating complication of multiple myeloma, which is CNS myeloma. So we know that it's a rare complication. Its incidence is 1% of multiple myeloma patients, but in my opinion, it is expected to rise as multiple myeloma patients live longer. It is mainly presented at the relapse setting. However, it's less often in newly diagnosed myeloma. In our series, this was 11%. But it may present also as isolated CNS involvement. This was 26% in our series. And we know that there are resistant clones, that they have the ability to survive outside that bone marrow microenvironment. The main pathway of evolution is hematogenous dissemination, and this is often associated with plasma cell leukemia, but we may have a contiguous spread from a cranial plasmacytoma. The median time to evolution ranges between 15 and 28 months. And according to epidemiology, patients are usually younger and they have high-risk features, including high-risk cytogenetics, high LDH, and extramedullary disease. As you can see, the clinical manifestations vary. There is a high heterogeneity, including paresis, visual disturbances, lethargy, headache, etc. Regarding pathogenesis, we know that it's common with other types of extramedullary disease, and it stands in two pillars. First of all, the bone marrow microenvironment alterations, including downregulations of both chemosecondary receptors and mainly addition molecules, such as CD56, or upregulation of CXCR4 by various growth factors. In addition, we have genetic aberrations, including primary genetic aberrations and acquisition of secondary events, including mostly deletion 17p, TP53, and RAS mutations or MYC mutations. So I choose to walk you through a real patient case in order to see the difficulties we face when we manage a patient with CNS relapse. So this is a 61-year-old male who was diagnosed in December 2020. He had an ultra-high-risk multiple myeloma, as he had 3 high-risk cytogenetics, including 1q21, deletion 17p, and translocation 414. He had a complex karyotype. And I want you to notice that he had 4% of circulating plasma cells, the peripheral blood, because which at that time was not, did not meet the criteria of plasma cell leukemia. However, it was a very high-risk feature. He had extensive bone disease and no other major issues. So this patient, according to the second revision of ISS, he had a median PFS of 20 months and the median overall survival of 38 months. At that time, daratumumab was not available, was not approved, so we decided to enroll the patient to the AMN24 trial and give him the chance to be enrolled in a trial where he could receive either ISA-KRD or KRD. Our patient was randomized to receive KRD. So he achieved a very good partial response after 4 cycles. We proceeded to stem cell harvest, and we are about to offer him the autologous transplantation. However, during this procedure, he had an early biochemical relapse, and we decided to withhold transplantation and proceed to a second-line treatment and enroll the patient at that time in DREAM7, where he was randomized to receive Bela-VD. As you can see, he indeed achieved complete remission. And after 9 months, during a routine PET-CT, which was obligatory from the protocol of the study, we noticed that he had nucleatic lesions, even though bone marrow was negative and he had an MRD negativity in the bone marrow. So at that time, we decided to move directly to autologous transplantation. He received high-dose melphalan, achieving, at June 2022, a PET-CT negative, and of course, MRD of the bone marrow was still negative. We were very happy after this result. However, a few months later, he complained about dizziness, dysarthria, intermittent tongue, and extremity numbness. So at this point, I want to address that in any multiple myeloma patient who has unexplained neurological symptoms, at any stage, we need to proceed and do an MRI of the entire neuraxis, along with cerebrospinal fluid analysis, to search for both clonal plasma cells and free light chains in the CNS. The MRI findings may include intraparenchymal lesions or leptomeningeal or both dural enhancement, as you can see in this beautiful image. You can see the leptomeningeal infiltration, you can see the masses, and this, which is called osteodural infiltration. This is a picture of the CSF of our patient. You can see the plasma cells in the CSF, and this is the next generation flow analysis confirming the clonal origin of our plasma cells. At the same time, the patient had relapsed in the bone marrow with 8% of plasma cells in the circulation. So we had concomitant CNS involvement, secondary plasma cell leukemia, and extramedullary disease, as he had several masses in many tissues. So this is a very devastating condition, and we should find the best option for these patients. But still we know that patients with CNS myeloma are excluded from clinical trials, so the number of patients is very small, and we don't have high quality data in order to guide our decisions in therapy. The current management largely parallels that of lymphomas with CNS and includes systemic therapy, intrathecal chemotherapy, and CNS irradiation. Of course, we need to adapt our decisions according to the presence of concurrent systemic myeloma. In many cases, we need to give a multimodal approach using the available treatment options in order to manage these patients. This is a busy table. What I would like to address is that the number of publications is very limited, and the number of patients included is also very limited. As you can see here, Arthur had the biggest series, which was a multi-centered, I guess, a multinational series of 172 patients published back to 2016. And what I would like to address here is that you can see the heterogeneity of the approach. Most of us give multimodal treatment, but what is also interesting is that there is a different definition which varies across studies. So you may see the median post-CNS MN survival ranging from 3 to 7 months. However, if you include patients with osteodural disease, you may see a median PFS reaching 25 months. This is our series published 2 years ago. This analysis included strictly patients with leptomeningeal infiltration and intraparenchymal masses, and as you can see, the median post-CNS survival was only 4 months, and of course, the median overall survival compared to a matched control of myeloma patients was significantly lower. According to prognostic factors for post-CNS MN survival, as you can see in several studies, systemic therapy, multi-dosing intrathecal chemotherapy, only focal brain myeloma, and the treatment after 2016 were positive prognostic factors, and the last reflects actually the improvement in multiple myeloma therapy after 2016. Regarding therapy, we know that the results from the proteasome inhibitor use is not very good. Only marizovit can cross the blood-brain barrier, but still we only have one small study by Ashraf Badr showing this. Regarding immunomodulatory drugs, things are better. Thalidomide and pomalidomide seem to cross the blood-brain barrier. And the CD38 also crosses barrier, and this was shown as drug was detected in the CSF of some patients. Selinexor may be a good approach as it is effective in extramedullary disease and in CNS diffuse large B-cell lymphoma, and we don't have any information regarding the efficacy of belantamab mafodotin or reloxizumab. On the other hand, I think that there is a chance to give some better treatment in our patients if we use the T-cell redirecting therapies. There are some case reports showing that indeed there is an efficacy if we use CAR-T, BCMA or BCMA bispecifics, and this is based actually on the proposed pathogenesis of CRS and ICANS. So we're expecting a lot of these drugs. I think that MEERA has recently published some data showing efficacy from bispecifics. But what is most important for me is how to predict the CNS evolution, because we know that if a patient has this devastating complication, it's very, very difficult to manage. So there are two studies. Our study showed that if you have preceding extramedullary disease and circulating plasma cells, this is a very strong prognostic factor for developing CNS myeloma. You can see a six-fold increase in the probability to develop CNS myeloma. And this was also confirmed by a study published earlier in Mayo Clinic by Paluda and colleagues, which also showed that the presence of high plasma cell Leipel index, extramedullary disease, or circulating plasma cells are strong predictors for evolution to CNS myeloma. So this was taken into account from the recently published EMN consensus statement on primary plasma cell leukemia. And what the panel suggested is that there is an increased risk for patients with plasma cell leukemia to develop CNS myeloma. Therefore, they recommended diagnostic lumbar puncture in patients with neurological symptoms. And also, we could consider this approach to selected patients, such as those with high number of circulating plasma cells, and preferably waiting for the disappearance after the initial treatment in order to avoid any spilling to the CNS. So going back to our patient, as you can see, he received a multimodal approach with VDT PACE, intrathecal RAC, alternate with high-dose methotrexate, and indeed we achieved alleviation of symptoms and complete response in bone marrow, an MRD negativity in the peripheral blood, and a negative PET-CT. We continued using a consolidation with selinexor, daratumumab, thalidomide, and dexamethasone in a desperate attempt to keep this response. However, a few months later, he relapsed with plasmablasts in the CNS. He had an intraparenchymal mass. He had systemic relapse also. We offered him high-dose methotrexate, cell-pom-dex, and finally, he died 10 months after CNS involvement from progressive disease and septic shock. And this is the mass in the intraparenchymal mass of our patient. So to summarize my presentation, I would like to give you some practical recommendations. First of all, we need to ensure the timely diagnosis with high clinical suspicion. As I said before, we need to monitor very strictly the high-risk myeloma patients, and of course, promptly evaluate any patient with unexplained neurological symptoms. The essential diagnostic steps include lumbar puncture, MRI of the whole neuroaxis, and sometimes we may need a stereotactic biopsy if there is any doubt for the diagnosis. We need additionally a full multiple myeloma restaging in order to make our treatment decisions. Regarding therapy, we use concomitant systemic therapy. We need to use drugs that cross the blood-brain barrier, and of course, we must decide according to the previous refractoriness or sensitivity. We know that if we use high-dose methotrexate, we may have transient response. However, it's highly toxic, so we should use it with caution. We need to use blood-brain cross agents. This should be included in our regimen. Regarding TCR therapies, I believe that this is a promising option, but we need to wait and see if we have any clinical trials. Intrathecal chemotherapy, even though it is debated, I would recommend to include it, especially for patients with leptomeningeal infiltration. Radiation therapy is another difficult decision. It's effective as part, though, of a multimodal approach. Leptomeningeal myeloma requires a whole craniospinal radiation, and this is technically challenging. Now we have new techniques, including bone marrow sparing proton therapy. However, this is a better option for patients who have focal brain masses because we can do a site-directed radiotherapy. We may also use it in intramedullary lesions. In my opinion, CNS prophylaxis may be reasonable for high-risk patients, following the approach we do in CNS involving DLBCL. And finally, the most important thing is that there is an urgent need to have prospective clinical trials for this difficult population, which we don't have until now. And this trial should include marizobib, TCR therapies, in order to find a solution finally for this population of patients. And this is the algorithm, which is published in the review we have recently wrote with Evangelos Terpos, and is going to be published soon enough in Hemisphere. Thank you very much for your attention.
Thank you very much. Any question to our speaker? Yes, please.
Difficult subject, although I think it's very rare. So we discussed a bit about this CNS myeloma. So first of all, I appreciate that you distinguish between, true CNS disease from paraskeletal extension, the compress, and the spinal cord. So it also causes CNS symptoms, but it's not CNS disease. So we only refer to CNS myeloma in case of parenchymal disease like yours, and also leptomeningeal disease as evidenced by the CSF myeloma cells. So I think this is number one, very important. The other thing is about your case. Very interesting, very high risk for folate transcription 17p deletion, and so something else I forgot. So SCOT3, yeah. So very exceedingly high risk in terms of cytogenetics. So, but still, what do you think is the cause of the CNS myeloma in your case? Do you think it's purely because of the high risk? High risk cytogenetic, biological high risk, so that's why they go into, because we still see quite a number of our patients, maybe some 20% of our patients may belong to high risk, still they don't have CNS myeloma.
Thank you for the very tough question. I'm not sure that I could answer this question completely. However, I think that on one hand, we have resistant clones as patients live longer and they acquire resistance. And on the other hand, there is a completely different biology, especially in patients that have circulating plasma cells. So we should be very careful to search for circulating plasma cells at diagnosis in order to follow those patients much more closely. Yeah. It's a matter of metastasis and circulation, I guess.
Yeah, thank you so much, because I'm actually driving at this, because I think the circulating plasma cells is more important, because we understand CNS myeloma is one form of extramedullary myeloma that is due to hematogenous spread. So yours is a good demonstration of the hematogenous spread, but so rare to the CNS. Yeah. So the other thing is about the treatment. So it's difficult. So I think the one point about the treatment is that what is so difficult is not only about the size. So because I think you cite a number of publication is scanty, small numbers, and yet we don't have, the TP53 mutation status. We understand that extramedullary disease is actually more enriched in TP53 mutation anyway. So I think for CNS myeloma, so we don't generally, I believe in all those publications that are retrospective, we don't have NGS in those days for TP53 mutation. I think it's actually one of the reasons, hypothetical, I believe this should be a research question for us to collaborate. So I think TP53 mutation is very important. In case so, whatever you do, whatever you give, is quite difficult to overcome TP53 mutation. And so what do you think?
I think that it's much more common to have TP53 mutations in patients who develop CNS or even secondary plasma cell leukemia. So it's very important to follow those patients very closely. And of course, as Rafael said, we need to give the best treatment initially in order to kill all these resistant clones from the beginning.
But you have succeeded because the patient was actually rendered MRD negative, CR.
Yes, but still it came back, yes.
So can I ask the next question? Because the whole picture reminds me of my patient with, acute lymphoblastic leukemia, who developed CNS relapse and subsequently systemic relapse. So it is exactly the case in yours. So my question to you is actually, what do you think is the cause of the systemic relapse in your patient? What's the source of the tumor cells?
A patient who has 3 high-risk cytogenetics has a very high probability for early progression. As you see in the initial treatment, the patient progressed within 6 months. This is per se a very negative prognostic factor for progression-free and overall survival for the patient. So it was not surprising that he developed extramedullary disease or he developed CNS myeloma. So the initial risk factors are very important for the course and finally the survival rate of such patients.
Because the reason I ask is that, do you think actually the cause of systemic relapse actually stems from the tumor cell, the plasma cells inside the CNS that actually goes back to the systemic circulation? Or, despite the fact that you achieve MRD negative CR, is a bone marrow CR from one side. So we are never sure about other sides of the disease. So you said that we have MRD 10 to minus 6 or 5, in your case, probably 5, 10 to minus 5 sensitivity MRD negative CR in that side. So what about the other side, opposite side, or actually other parts of the body? So that's always my question about MRD. I think it's certainly it's been validated by Piper et al. So, but still, yes, because you show a case, so that triggered me to think about what exactly is the tumor cells that actually cause the systemic relapse.
This is a good point because we cannot evaluate MRD everywhere.
Yeah, sure,
we have the PET-CT, of course, we have the NGF or the NGS. However, we may still have cells circulating. That's why it's important to recognize those cells very early and try to follow them and achieve an MRD in the peripheral blood, which is also important. You know that this CTCs issue is rising now. We know that it's not 5%, it's even much lower. It may be 0.02, as Evangelos Terpos showed with his recent publication. So I think that we underestimated circulating plasma cells, and we need to focus on that in order to avoid this complication afterwards, CNS and other extramedullary, of course, disease, because it's not only CNS MMS. As you saw, he had lymph nodes, he had pleural infusions, and this was a really very aggressive case. Yeah. And I don't know if we had CAR T cells, if we would have the time to give a bridging therapy to such a patient.
Yeah, and finally about marisomib. So this is the only, marisomib, this is the only proteasome inhibitor that penetrated CNS. I think Andrew Spencer actually published a case series in the British Journal of Hematology a number of years ago, and somehow the whole thing actually disappeared from...
Yes, yeah, because I think only marisomib can cross blood-brain barrier because, however, blood-brain barrier in these patients is disrupted anyway, so some drugs may pass. However, this is not the case for, let's say, bortezomib. And another thing is that we cannot give bortezomib together with radiation because it is very toxic, and I need to address this.
Thank you so much.
Thank you very much. Thank you very much.
Okay.
Dear friends, in summing up of the session, we're faced with really global approach to multiple myeloma from United States of America through Greece, Germany, India, and we'll be faced with other countries, Germany. And I have pleasure to remind two more persons in our society. First is Professor Anna Dmoszyńska, who introduced in Poland thalidomide about 20 years ago, and as you show, thalidomide in 42% penetrate to central nervous system. So chapeau bas to Anna Dmoszyńska. And second person I would like to mention is our friend from Karolinska Institute in Stockholm, Professor Gösta Garton, who to some extent was precursor of what we are talking now about T-cell approach in the treatment. He, as you know, was very fond of allogeneic stem cell transplantation and taking advantage of T-cell in graft material against multiple myeloma. And whatever we are doing now, immunomodulatory treatment by specific T-cell or CAR-T, is continuation to some extent of what he stated many years ago, that allogeneic stem cell in multiple myeloma in patients who survive with therapy could be completely cured. My impression is that multiple myeloma became sometimes chronic disease with so-called smoldering multiple myeloma after many approaches, and the time in which patient could survive with smoldering with MRD very low is thanks to immune system who is taking over of continuation of multiplication of production of monoclonals, like it happened in Magus. As you know, Magus transformed to open multiple myeloma when T-cell dependent immunity decreases. It was proved. So Gösta Garton, who is still living, as far as I know, in Stockholm, was a precursor, and I think it's worthwhile to mention about this person. Artur, I think we are going to invite all of you for a small lunch, and the teacher will be in front of this table, and I already invite you, I think, at 3 o'clock at second session. So make your face and duty in terms of women very ready for a good picture. Thank you very much.
Welcome everybody after the break. We would like to start sharp second session. I would like to ask Professor Tomasz Sacha, Dr. Wojciech Legieć, and Professor Bogusław Machaliński to be a chairman second session. We have 4 lectures, and first will be our friend from Ireland, Professor Michael O'Dwyer. Second? Okay. Okay, good. So the stage is yours. Okay.
Okay, so Michael is a very old friend of us and a very good friend. He's coming from Galway University, and he's conducting the research on immunotherapy in multiple myeloma, and he is in the search of reliable biomarkers of patients with high risk and worse outcome of treatment. So please tell us about the immunotherapy in high-risk patients.
Thanks very much, Thomas. So it's a great pleasure indeed to be here in Krakow, and thank you very much, Artur and Eva and the organizers for all the work put into the meeting, and it's genuinely been very enjoyable and great hospitality so far, and I'm looking forward to the remainder of my time here. So what I'm going to do is talk in the first maybe 7 slides or so about immunotherapy and in putting high-risk features in context and what we can expect with response to upfront treatment with daratumumab. And then I'm going to talk a little bit about some of my own research that may provide some novel new insights into daratumumab resistance. So you've already seen this presented earlier, but this is from the PERSEUS study And Perseus and Cassiopeia have really put quadruplets containing CD38 antibodies to the forefront as standard of care for treatment of newly diagnosed transplant-eligible patients with multiple myeloma. And what I want to just focus on here is the fact, obviously, patients got either VRD all along as induction, then transplant consolidation, and then lenalidomide maintenance, or the same with the addition of daratumumab. And daratumumab in the maintenance phase was given for a minimum of 2 years, and patients who had sustained MRD negativity for at least 12 months beyond 2 years were then in a position to stop daratumumab, and they could restart daratumumab if they became MRD positive again. So you've already seen this, and it shows that clearly the addition of daratumumab to VRD-based therapy led to a very impressive improvement in progression-free survival. And so why is that? Well, the reason is that patients who get treated with daratumumab have a much higher rate of achieving deep MRD negative responses. And if you look up here, what you can actually see is that in patients, regardless of the treatment that they received, if patients achieve sustained MRD negativity, those patients have an amazingly impressive progression-free survival. And it doesn't really matter, as I said, which treatment, as long as you get to having a sustained MRD negative response. But clearly, if you get daratumumab, you're much more likely, you have at least twice the likelihood of achieving that deep MRD negative response. And if you look over time, approximately 2/3 of patients who get treated with daratumumab are eventually in a position where beyond 2 years, because they have a sustained MRD negative response, they're able to stop the daratumumab, at least. They continue on the lenalidomide, but they're able to stop daratumumab maintenance. And, oops, sorry, I keep pressing the wrong button. But in these patients, the likelihood of having subsequent MRD, conversion to MRD positivity is actually very low. And in fact, with the daratumumab, in patients who were MRD positive at the time of going on maintenance, the patients who got the daratumumab were 3 times more likely to subsequently become MRD negative. So how does this apply to patients with high-risk features? Well, in actual fact, patients who had high risk, and high risk, of course, is based on 17p deletion, 414 and 1416 translocations, those patients also do quite well. They're much more likely to achieve sustained MRD negativity than patients receiving VRD if they receive, daratumumab. And while not statistically significant, there is a suggestion that these patients also have better progression-free survival. So if we look at MRD negativity across the different subgroups, it would appear based on the forest plot that patients with ISS3 and highlighted here, high-risk cytogenetic features, that they benefit just like everybody else from the addition of daratumumab. The only thing is perhaps they don't benefit, arguably, quite as much as patients with standard risk. And if we look at PFS then, according to presence of high-risk features, patients, the odds ratio, or the hazard ratio rather, for progression is not as impressive as in the standard risk group. And if you look at the numbers, with DVRD, only 9% of standard risk patients progressed, as opposed to 32% of high-risk patients. But of course, the confidence intervals are very wide because of the very small sample size, so we can't say definitively that they do any differently. But again, the high risk is defined only as del17p, 414 or 1416. And what we now know is that this may not have been the best assessment of risk, and we're moving on to incorporation of new risk features into classification of risk. And this is the recent paper in the Journal of Clinical Oncology, and it's now accepted that del(17p) with the cutoff of 20% is poor risk, and for the first time, p53 mutation on its own is now accepted as a high-risk feature. But 414 or 1416 on their own are no longer considered high risk. But if you do have, and this is not uncommon, the addition of 1Q or 1Q amplification, then this does actually put you into a high risk. And maybe about, 75% of patients with 414 may have a 1Q as well. And other factors, of course, 1P is in for the first time, beta-2 microglobulin greater than 5.5 in the absence of renal failure. And then there are other factors we've heard about, such as circulating tumor cells, extramedullary disease, and indeed high-risk gene expression profile that in the future may become incorporated into risk classification. And indeed, there's a paper just out in Blood which shows that if you incorporate gene expression profile, you may actually be able to identify, along with IMS classification, most of the patients who progress early. And so there are very few so-called functional high-risk patients left. So what now if we start, this isn't quite IMS new classification, but it is taking into account the presence of 1Q. And so in an analysis of the MASTER study and the Griffin study, a joint analysis looking at the impact of high-risk cytogenetic abnormalities on progression-free survival, it appears that if you have only one of these features, that the difference in PFS there's no real difference compared to patients who don't have any high-risk features. But if you have two or more of these high-risk features, then progression rates are quite different. And so patients are at much higher risk of progression if you have, for example, 414 and 1Q together. And this is something I think in future, and in studies like the PERSEUS, maybe they'll have to go back and try and figure out, how does this impact on risk in that patient population. So is there anything that we can do about high risk? Well, if you have approximately 10% of patients in the MASTER and Griffin who had two or more high-risk features and who ultimately had inferior PFS, is there any way of potentially rescuing these patients? And maybe more intensive therapy is one possibility. This is the ISKIA study where carfilzomib was used instead of bortezomib, and it's sort of a long, drawn-out sort of consolidation, so ongoing treatment. And the bottom line in this study was presented at plenary at ASH in 2023, and more recently at ASCO, is that with the addition of carfilzomib with isatuximab, in this case as opposed to daratumumab, that in fact patients with two or more high-risk cytogenetic abnormalities actually achieve a much higher rate of MRD negativity at a level of 10 to the minus 6. So maybe if you can do it in high-risk patients, maybe the incorporation of carfilzomib may be something to think about. Now, I really don't have time to go into much more about optimization of management in high-risk patients, but what I wanted to do instead was to maybe focus a little bit on why is it that patients may actually become resistant to daratumumab in the first place. And so, some insights from my own work that could be relevant. So this is basically my own depiction of a cartoon that some of you are sort of familiar with, which is depicting the different mechanisms of action of CD38 antibodies. So of course, ADCC mediated by NK cells is very important. You need FC receptors to recognize the antibody. Antibody-dependent cellular phagocytosis mediated by macrophages is another important mechanism. Complement-dependent cytotoxicity. And then ultimately, the innate immune system triggers a subsequent adaptive immune response with clonal T cell expansion. And the elimination of CD38 positive regulatory T cells and also MDSCs certainly helps that clonal expansion to occur. But what are the mechanisms of resistance? On the other hand, if you don't have sufficient numbers of functioning NK cells, then that's a problem. And of course, daratumumab is going to lead to some fratricide of NK cells because the NK cell does express CD38. But also in patients, even before they ever receive daratumumab, a proportion of patients have low levels of CD16 positive NK cells, and they also have a reduction in a very important co-stimulatory or activating molecule known as DNAM1, and this has been published recently. Also, polarization of macrophages to a more pro-tumorigenic phenotype is associated with resistance. An increase in complement inhibitory proteins such as CD55 or CD59, downregulation of CD38, and ultimately failure to expand your T cell population and maybe have exhaustion of T cells with upregulation of immune checkpoint receptors. All of these things conspire to lead to daratumumab resistance. Now, some years ago, I took an interest in post-translational modification with glycosylation, and we identified, this is going back over 10 years ago, that myeloma cells were hypersialylated and that this played an important role in cellular trafficking. So in other words, how myeloma cells navigate through the circulation in and out of the bone marrow using, in this case, selectin ligands. But of course, another very important family of receptors that sialic acid binds to are known as the Siglecs. And Siglecs are effectively immune checkpoint receptors analogous to PD-1, as shown here on binding of sialic acid like PD-1. These Siglec receptors, which are present on different immune cell types, have an inhibitory sort of motif in the intracytoplasmic domain, which leads to inhibition of cellular signaling. And so sialic acid binding to immune cells expressing Siglecs leads to inhibition of the immune response. So there's a number of papers in both the solid tumor literature and in blood cancers showing that increased expression of sialic acids mediated by the enzymes such as ST3-GAL1, which I'll mention in a minute, leads to immune evasion in this case, a number of solid tumors. Also, I'd point out that silation of CD55, which is a complement inhibitory protein, has been implicated in inhibition of complement-dependent cytotoxicity. So a number of blood cancers, I'll just point out this isn't myeloma, but in the context of lymphoma, it was shown that MYC, very well known to be important in myeloma biology, drives the expression of the Siglec ligands that ultimately lead to generation of a don't eat me signal, so inhibition of phagocytosis. And so putting all of this together, we came up with a hypothesis that sialylation could potentially inhibit all of the mechanisms that are associated with response to daratumumab, and so potentially could be an important mechanism of resistance. And based on some of our own insights and some of what was known from the literature around the biology of making sialic acid structures, we kind of focused on several of these cell transferases that might be involved in this process. And so to begin with, we looked at multiple myeloma cells. These are patient samples and cell lines, and found that they highly expressed these sugar ligands for these Siglec receptors. And we also found that when we looked at both NK cells and macrophages, that there were high levels of the receptors on these immune cells at a higher level than is seen on their normal counterparts. Now, what we found is that when we remove sialic acid from myeloma cell lines, that we saw both enhancement of NK cytotoxicity, ADCC in the presence of daratumumab, antibody-dependent cellular phagocytosis, at least in one cell line, and also complement-dependent cytotoxicity. So all of the things that are relevant to daratumumab are improved if you remove sialic acid from the surface of myeloma cells in the presence of daratumumab. And what we also did was use CRISPR to knock out the Siglec receptor on NK cells, and when we did that then, and the NK cells were no longer subject to this inhibition, then we saw enhanced ADCC as well. So this supports the idea that, yes, the sialic acid-Siglec interaction is actually quite important. So what we had done was also to actually using a kind of a immunoprecipitation technique, we co-incubated myeloma cells with a recombinant Siglec-7. We were able to pull out whatever it was binding to, and by mass spectrometry, we were able to identify that the ligand, or the Siglec-7 ligand, was PSGL1, which has been known to play an important role in myeloma biology. And we found when we looked at this ST3-GAL1 gene and knocked it out using CRISPR, and we knocked out a number of different cell transferases, that there was complete elimination of Siglec-7 ligands. So we were able to say that this enzyme was making Siglec-7 ligands that are interacting with Siglec-7 in multiple myeloma. So back to clinical stuff. Cassiopeia, so sort of somewhat similar to Perseus. In this case, it's VTD versus VTD plus DARA, and patients in the maintenance phase got either DARA monotherapy or observation, which was actually, believe it or not, standard of care at that time. And what we first of all did was looked at all the different cell transferases by RNA sequencing, bulk sequencing in the clinical trial, and the only one at the beginning of the study that came out as being significant for progression-free survival was this gene ST3-GAL1. And what we found is that within patients who received daratumumab, that if the gene level was at a higher level, that in the study as a whole, there was inferior progression-free survival. So are there associations with any high-risk features? Well, indeed, by looking at the gene signature for sort of the 414, if you like, and 1416, there was a correlation between 414, 1416, and increased expression of ST3-GAL1, and separately looking within the COMPASS study in patients who had 414 translocation, there was significantly higher levels of expression of ST3-GAL1. And interestingly, we've talked a little bit about 1Q, and 1Q copy as it goes up being a bad thing in myeloma, and in fact, ST3-GAL1 expression goes up with increasing 1Q copy number, but also, sorry, trigger happy here, also SLPLG is actually PSGL1. This actually goes up. So you have a double effect of, if you like, the glycoprotein that is being modified by the sugar, both going up with 1Q amplification. So within the Cassiopeia study, we were actually interested in what happens to patients who are already MRD negative at the time that they go on to maintenance therapy. And if you just look at patients who are already MRD negative and look at what happens to them 2 years later, according to expression of this gene, if patients had higher levels of the ST3-GAL1, they were more likely to lose their MRD negativity. And this ultimately translated into inferior progression-free survival, as shown here. So we found a marker that predicts a lack of sustained MRD negativity in patients with multiple myeloma. Now, what I mentioned to you is that this is an enzyme that's modifying an underlying glycoprotein, and if we put these two bits of information together, what the green curve is showing you is the overall survival, and this is 6 years post the second randomization, the overall survival of patients who have normal expression of the two genes, the ST3-GAL1 and the PSGL1. In contrast, this curve down here represents the overall survival of patients who have high levels of both. So the glycoprotein being modified by the enzyme and the hazard ratio of 5.3 between these two. You can't calculate a hazard ratio between 100% overall survival and 71% because it would be infinity. So, but there's a 5.3-fold increased risk of death in patients who have two abnormalities as opposed to one.
And the final thing that I just wanted to show was that PSGL1 was reported in a Science Immunology paper a few months ago to be a new immune checkpoint, and which was governing phagocytosis, and this was shown in the context of AML and also in multiple myeloma. They completely missed the fact that PSGL1 is, in fact, a ligand for the Siglex as well. But what I'm showing you here is now if we use an antibody, just a blocking antibody, I showed you what we can do if we remove sialic acids, but if we use a blocking antibody to PSGL1, this is MM1S cells, and we incubate with NK cells. I'm just showing you one effector to target cell ratio, but it's consistent across ET ratios, that there's significant enhancement of NK cytotoxicity just by blocking this glycoprotein. So effectively, we believe that this glycoprotein, when modified by this enzyme, not on its own, it has to be modified, may be a new immune checkpoint in multiple myeloma. So with that, I'm going to conclude. These are my various collaborators. I'm very thankful to Peter Sonneveld for giving me some of the slides that I showed you at the beginning relating to the Perseus study. And without my collaborators in Nantes, I wouldn't have been able to do this work. So thank you.
Thank you, Michael, for this excellent lecture. Are there any questions from the audience? Michael, is this abnormality, this ST3-GAL1, druggable, do you think?
So the only thing we know really is that if this is increased at a transcriptional level at baseline, that it has this subsequent impact on prognosis. And so it's not something that is likely to be due to copy number alterations. It's probably something that is more transcriptionally regulated. And so we know that, a number of different, if you like, environmental cues like hypoxia, like TGF-beta, like PGE2, for example, within the tumor microenvironment, can all drive increased transcription of this gene. And what I showed you in relation to 1q, it's not on chromosome 1, the gene, but it's probably through some sort of circuit that transcriptionally it's upregulated. So that's kind of as much really as we know, but what we think, of course, is that by being induced, that this is generating these sugars that are essentially masking the cells that are making them, able to evade recognition by the immune system, and so immunosurveillance is just not happening. And we've some evidence, in fact, that this may also be a factor in extramedullary disease. So my colleague in Dublin, Siobhan Glavy, is hopefully going to present some data around this at ASH.
Do you think that you could define some cutoff level of WAF of this gene, or is it?
I think that would be very difficult. I'm not, I'm not a genomics person, but I know that this type of analysis is more, if you like, population-based rather than being able to, be actionable on an individual patient basis. But having said that, what I showed you at the end, there's roughly a quarter of patients, I think it might be 28% of patients who were in the DARA VTD DARA group, the group who did best of all in the Cassiopeia study, who have higher levels of both of these genes, and where it does seem, though, to some extent segregate with recognized high-risk features. And so is it possible that patients with 414 and 1q may be the patients who respond better to this type of therapy, if we had such a therapy? Who knows?
Thank you very much. Any other question? Yes, Jim?
So can I ask, I'm not familiar with the topic, but the thing is, can I ask, like PD-1 is inducible. This is when the T cell the tumor-specific T cell get activated and binding to the tumor cells. So is the SILEC receptor inducible or just constitutive expressed?
So on NK cells, the Siglec-7 receptors are constitutively expressed. And in fact, ironically, lower levels of Siglec-7 expression on NK cells is probably a feature of dysfunction and exhaustion. So in HIV, in chronic hepatitis C, circulating NK cells often have lower levels of expression. But in relation to other cellular subsets and macrophages, T cells, for example, it's often a case that they're actually induced within the tumor microenvironment. And so, circulating normal T cells typically don't express Siglec receptors, but if you find intratumoral T cells, then they do.
So in the case when you talk about the daratumumab-induced resistance, so it's related to cyatination and also the expression of the Siglec receptor. So it's a ligand receptor binding that induces inhibition of the immune cell function.
Yeah.
The thing is, how does it, I cannot reconcile. So when you prolong exposure to DARA, are you selecting a clone that has got a high cyatination, therefore it induces resistant immune cell compromise? Or are you inducing a high cyatination? The DARA actually induces cyatination of the tumor cells?
Well, the data we have is based on expression levels pre-DARA. So the patient hasn't seen any DARA. These are baseline samples prior to the patient is being enrolled to go on the clinical trial. So it reflects the inherent biology of the disease and not a response to the treatment. We think that the ligand receptor interaction is important, but it's not the only mechanism whereby silylation could be important. So we actually showed previously that CD38, for example, is post-translationally modified by sialic acid. So if you actually remove sialic acid, that there's higher levels of expression of CD38. And I'm not sure if Hermann is here, but Hermann Einsele's group has actually looked using their high-resolution microscopy and seen that multiple common tumor antigens, when you remove sialic acid from the cells, that there's higher expression of BCMA, CD38, so on. So, and also just immune synapse formation, how an immune cell can interact with a target cell completely independently of any Siglec interaction. Just as a physical barrier, it's almost like steric hindrance that an immune cell can't lock on to a target cell properly if there's lots of negatively charged sialic acids on the cell surface.
Thank you.
Okay, if no further questions, thank you, Michael.
Thank you.
Excellent lecture. And I hand over the chairing to Professor Maliński.
Thank you very much. Professor Zacha. Professor James Chim has just asked a few questions. Now, this is my great pleasure to briefly introduce him. Professor Chim is a honorary clinician, professor working at the University Department of Medicine at the University of Hong Kong, as well as he is honorary clinician professor of the Department of Medicine and Therapeutics at the Chinese University of Hong Kong. He's a very distinguished scientist as well as clinician in the world. So we all are waiting for his lecture, High-Risk Multiple Myeloma, a Moving Target and Unmet Medical Need.
So thank you very much for your kind introduction. So first of all, thank you, Arthur, for your kind invitation too. It's actually my honor and pleasure to come to Krakow for the first time. I'm really impressed because actually I was in Milan for the EHA in June, and then I was in Germany for 2 weeks in July, and actually in comparison, I like Krakow most. All right, so thank you so much. I'm James from Hong Kong, so I'm going to talk about high-risk myeloma. So it's a moving target. Apparently, I think Michael has already talked about a lot about high-risk already, so I hope that I'm not going to bore you too much. So first of all, the risk factor for myeloma usually occurs is about features of diagnosis, but also there are dynamic risk factors, including, say, the response to therapy, for instance, a primary refractory disease, or actually patient functional high risk, as alluded by Michael as well. So those are early relapse or suboptimal response, or early relapse include those patients who actually relapse within 12 months of ASCT or 18 months from the start of treatment in non-transplant candidates, and also include or multi-response after transplant or consolidation or pre-maintenance. So in that connection, though, we have to think about whether the sensitivity level matters, for instance, ML5 or ML6, is it MLD negative? Because MLD negativity does not correlate CR, so there is a little bit discrepancy between, so there are also patients without CR who are also MLD negative. So should we refer to MLD negative CR, or actually I think probably the most important thing is actually are they able to sustain the MLD negativity? And also I think the PAC-CT response is also important after treatment, be it ASCT or actually after induction. So I think for a long time, because there are a lot of advances in multiple myeloma, prolonged survival so much, so for a long time we've been referring patients to standard risk or high risk. However good we treat our patients, still there remains a population of patients who has we call it ultra high risk with a very short survival around 3 years. So who are these patients? So these are patients with presenting with extramedullary disease diagnosis of circulating tumor cells, and also these are patients with either deletion 17p or actually by allelic TP53 inactivation with a concurrent mutation of the TP53 gene. And also there are also patients with high-risk GP, and also patients with multiple hits that is a concurrent high-risk cytogenetic alterations. And also as alluded to, there are also dynamic risk factors, including the response to initial therapy. So for a long time, we've been using this international staging system, so simple, okay, we are so happy, okay. So however, after some time, we know that in 2015, we know that actually the RS is not sufficient, so therefore we incorporate LDH and also MWG high-risk cytogenetic alteration. There are only 3 for 14, 46, and also 17p deletion to actually form the revised ISS. And recently, the French group also proposed another cytogenetic scoring system. We call it a weighted cytogenetic scoring system, because actually they expand the first panel to include transmit data, 1P and 1Q, and also they assign a weight or coefficient to each of these high-risk cytogenetic alterations. And more recently, we have this ARTUR ISS. So basically, they also include 1Q data, and also they assign a weight to each of the clinical parameters. Basically, the whole aim is to refine RIS2 category. So, and more recently, again, so we are moving on to so-called ultra high risk, because there is a lot of interest in using this definition now. That is among a panel of high risk cytogenetic alterations, a patient carrying 2 or more of these high risk cytogenetic alteration. So I think there is a lot of complexity about the definition of high risk in myeloma. So first of all, which genes and alterations, apart from 1P, 1Q, 4, 40, 16, 40, 20, or 70p deletion, are important? And second, how do we assign, a coefficient, a differential weight to each of these cytogenetic factors? Probably they do not, behave the same. And what about metaphase? Because we know that metaphase is able to catch some of those, high-risk cytogenetic aberrations like hypodiploidy or near tetraploidy that can be detected by FISH. So, and also in that connection, how frequent are they? So also the clone size has been quite debatable, because for a long time, for instance, the 17p deletion for the French colleagues, they insisted that it has to be more than 55% of the clone size before it impose an adverse impact. And so for 1Q data also, so is it 3 copies or 4 copies? There is a lot of discussion. And also location breakpoint is also important, because MSAT that was in the past, so now it's called NSD2, so that was involved in the 414 translocation. We understand that the early, the more 5' breakpoint in this gene does not confer adverse impact on survival. And so the last question is, how do we integrate all these high-risk cytogenetic alterations to the clinical parameters?
So for Hong Kong Society of Myeloma, we've been collecting data from major hospitals for more than 10 years. So altogether, we have some 450 patients altogether. So majority of them actually had received a bortezomib-based triplet induction in more than 220 cases. We have complete cytogenetic data. And the cutoff threshold for the facial aberration is that 20% for 17p deletion and 10% for translocations. So we make a study, we just want to study the performance of the current different risk scoring systems in Hong Kong. So in connection to international staging system, WG high risk, RISS, auto ISS, the weighted cytogenetic scoring system, and also the ultra high risk category. So this is actually the survival, overall survival of patients actually categorized by ISS or RISS. You see that the patient with stage 3 disease has a much inferior survival, and this has been published in Bone Marrow Transplant last year. So what are MWG defined high risk? So the only 3 factors for 14, 46, and 17p deletions. So you see that the patient with either of these high risk MWG high risk HRCA will have inferior survival. So what about RISS, the revised RISS? So we see that on the left-hand side, this is overall survival. So first of all, we see that patients with RISS 1 and 2 disease actually have overlapping survival of both OS and also event-free survival. And however, patients with stage 3 disease has a very poor survival, only 3.5 years. So we believe that given that all these patients receive bortezomib-based triplet induction, so they have only a survival only 14 months, so I believe this is truly high risk. So what about ARTUR ISS? So as I alluded to, basically the point is that they include 1Q data. They also assign a weight to each of these parameters. So the whole point, if you look at the right-hand side, you see survival curves. So the dotted lines you see belongs to RISS 1 and 3, respectively. And this one belongs to the patient with RISS 2. Because actually more than 60% of the myeloma patient will fall into RISS 2. However, they have heterogeneous outcome. So actually the goal of the classification is actually to further dissect actually the outcome of this mixed batch of patients in RISS 2. And with all these criteria, so they are able to, to redefine RISS 2 into intermediate low and intermediate high risk category. So what do we apply this criteria to our cohort patients? So what are we seeing? So first of all, we see that on the left-hand side, patients with intermediate low and intermediate high actually had overlapping survival. So apparently, this RISS does fail the goal of refining RISS 2 in our cohort patients, and does not add further information. So what about this? This is a French, the French colleagues actually proposed this cytogenetic scoring system, and they assign a weight, so therefore I call it a weighted cytogenetic scoring system, WCSS. So there are a few features. One is that they include trisomy data, trisomy 5 and 21, and they also include 1P and 1Q data. And secondly, they also assign to each of these high-risk cytogenetic alteration a weight or a coefficient. Okay, so for instance, if you look at this trisomy data, trisomy 5 is a favorable factor, so therefore it has got a negative coefficient. And however, trisomy 21 has got a adverse impact, then therefore they got a positive factor. And as I alluded to, they also include 1P and 1P data as well. And patient with a score more than 1 has got is classified as high risk. So you see that patient with a score more than 1 has got a median survival of less than 3 years and actually less than 2.5 years, and so therefore it's truly ultra high risk. So what about if we apply this criteria to our cohort patients? First of all, we don't have trisomy data, so we have to ignore the trisomy data. But even by omitting the trisomy data, we are able to see that this system still is able to enable us to see 3 separate survival curves. So we see that so these are patients with these are high-risk patients with a score more than 1. So on the left-hand side, you see that the survival is only 3 years, given that majority of our patients receive bortezomib-based triplet induction, and a survival only 3 years is really, really very bad. So we believe that this WCSS is able to identify a cohort of ultra high-risk myeloma patients with a very short survival. So through all this, evolution, so now we are we moving on to this new category of ultra-high-risk classification? That is among a panel of HRCA high-risk solid genetic alterations, like for 1670p deletion, 1q or 1 plus 1p, or even including 1420. So any patients who carry 2 or more of these high-risk solid genetic alterations will be classified as ultra-high-risk. So indeed, in this year, JCO actually was verified that in the meta-analysis that, so in this meta-analysis, the notion of ultra-high-risk that is carrying more than 2 or more of this high-risk solid genetic alteration was validated in a meta-analysis of 24 recent RCTs of newly diagnosed and also relapsed refractory myeloma involving some 14,000 patients. So therefore, this ultra-high-risk category appears to be validated. So if we apply the same criteria again to our patients, so what we see, this is, so we have a slightly different panel. So our high-risk comprises only 5 factors, 4, 14, 40, 16, 70p deletion, 1p, and 1q. So if we look at this, so these are overall survival of patients without any of these 5. They have the best survival. These are patients with 1 of these 5. These are patients with 2 of these 5, and these are patients with 3 of these 5, and these are patients with 4 of these 5. So we appreciate actually there is an increasing adverse impact on overall survival by increasing the number of these high-risk solid genetic alterations. So again, if we just follow their criteria, these are patients without any of the 5 high-risk solid genetic alterations. These are patients with 1 and 2. So patients with 2 or more of these high-risk solid genetic alterations got a survival of 50 months. So if I summarize, so by applying the current risk stratification system to our cohort patient, we think that this modified the French group, so this modified weighted solid genetic scoring system appears to perform the best in cohort patients because it identifies cohort patients around 20% of the cohort with a very short survival, only 3 years. So what about the story of 1q and 17p deletion in Hong Kong? So this is I think the 1q story is quite complex. So first of all, if you look at the overall survival curve for patients with or without 1q, 1q plus, okay? So the question, I think it's not valid. Reason being that, so in patients without 1q, they might still have other high-risk solid genetic alterations like translocations, 1p deletion, 17p deletion, or combination of the above. And the same applies to patients with 1q gain, so they may still have other concurrent high-risk solid genetic alterations. And therefore, what is the true impact of 1q only? Okay, so again, so we just look at it in a slightly different way. So this is, first of all, this is a survival patient without any of these 5 high-risk solid genetic alterations. So these are patients with 1q only, okay? So, and this is the patient with 1q in combination with other high-risk solid genetic alteration. And therefore, first of all, we think that conventional wisdom fails to elucidate the true prognostic impact of 1q only. And secondly, the adverse impact of 1q is much enhanced by additional high-risk solid genetic alterations. And therefore, 1q only is probably high risk, but the 1q combo is ultra high risk. So what does 1q matter? So you look at the post-relapse survival. So this is again over survival for patient relapse. So, so for patients with 1q, when they relapse, they have a much inferior survival than patients with the 1q when they relapse. And secondly, so the next question to ask is, does ASCT help in patient with 1q? So you see that actually patients with 1q, if they undergo ASCT, their overall survival is improved. However, a greater survival benefit belongs to patients with the 1q and yet still go through ASCT. So this has been published earlier, a few years back. So then does deletion 17p warrant a separate page? So, the UK, Gareth Morgan and Brian Walker, they have published almost 10 years ago about, that, first of all, they think that 17p deletion only does not confer an adverse impact on survival. However, the French does not agree. They think that 17p deletion alone has got an adverse impact on survival. However, both of them agree that if the patient has got biallelic inactivation TP53 by deletion 17p concurrent with a TP53 mutation, then they have the worst survival. So what about in our case? So this is again overall survival, patient with none of the 5 high-risk genetic alterations. So this is the patient with 1q only, okay? So this is a patient with translocation. And this is a patient with 17p deletion. So you can see that patient with 17p deletion has got the worst survival, and therefore perhaps that 17p deletion warrants a separate page. So you see that this the Mayo Clinic, high-risk myeloma definitions or classification. So version 2.0, we have an intermediate risk category in which 440 is actually belongs to intermediate risk. And then 3.0, so they expanded, so first of all, the intermediate risk was missing, and then we have they expanded high-risk category. They also include TP53 mutation, 1q gain, but they retain RSS3 in this high-risk population. And the notion, the idea of double hit and triple hit myeloma emerges in this version 3.0. But what about this year? As Michael alluded to, so we have a new definition of high risk, now a 17p deletion alone with cutoff 20% of the tumor cells is already high risk in its own right, and 70p TP53 mutation again in its own right is a high risk parameter. And patient with 1p, they have to require biallelic deletion of 1p deletion. And then for patient with translocation, they are not. No, okay, so translocation alone is no longer high risk in its own right. They are only high risk if they are they occur in combination with either 1q or 1p deletion, or of course a 1p plus 1q is also another high risk definition. And what about beta-2M, beta-2 microglobulin is only high risk if the renal function is normal. So again, you see that the definition of high-risk myeloma keep evolving, keep moving, so it's quite difficult to catch. So therefore, the conclusion about risk stratification is that, first of all, the current MWG-defined high-risk first is inadequate. So we expand panel is needed. So conventional wisdom of 1q plus versus 1q negative cannot elucidate the true adverse impact of 1q only. And the same notion actually applies to other genetic alterations like translocation or 17p deletion. And the deletion 17p appears to warrant a separate page and the weighted cytogenetic scoring system because it assigns a different weight to each of this HRCA. Therefore, the risk escalation inherent with combination of this HRCA will be accounted for by adding the risk score. So in our cohort patient, we think that the WCSS, the weighted cytogenetic scoring system, even when omitting the trisomy data, still enable us to identify truly ultra-high-risk myeloma patients with a very short survival of only 3 years, and hence preferred. So the next question is, do we need a re-stratified approach for high-risk myeloma? So first of all, we see from this determination study that patient with a high-risk myeloma, this is actually subgroup analysis, and this is published in the supplementary data. So if you look at the subgroup analysis, so patient with high-risk myeloma, so if they receive a very potent VLD triplet induction and consolidation, they still have a very poor survival. So therefore, probably they need a re-stratified approach. So currently we know that achieving MLD negativity is the only way to overcome the adverse impact of high risk. Okay, so then we can ask the question to achieve it, in order to achieve a high rate of MLD negative in high risk myeloma. So can we use more potent proteasome inhibitor upfront, like carfilzomib, like RAFAEL do, and add on CD30 antibody, intensify treatment using tandem transplant, and fortify the maintenance. For instance, we give a double or triple maintenance. So currently, the outcome of high-risk myeloma are only derived from, majority of data are derived from these all-comer studies with subgroup analysis. And there is a number of issues about this subgroup analysis in these all-comer studies. First of all, there is the fraction of high risk is really small, and these studies are not powered to study high risk. And also, usually the favorable impact of the experimental arm on the high risk subgroup or standard risk subgroup is not presented in different survival curves. And then, however, there are also all-comer studies in which high-risk patients are enriched, including the FORTE study and the MASTER study. And of course, recently we have some designated study for high-risk myeloma only, including the French IFM, the German GMMG concept, and the UK Optimum. So as we alluded to, the MLD negativity can abolish the adverse impact of high risk, and therefore MLD negative is the goal of therapy in high-risk myeloma patients. So you look at depending on how you define high risk, for instance, you define high risk by RSS-free or ultra high risk, you can see that the patients achieving MLD negativity has got the same favorable survival as those standard risk patients. So how do we tackle high-risk myeloma patients? The question is, does ASCT help? Should we intensify the treatment using tandem transplant, add on CD38 antibody, and then switch to confusion as I alluded to? So if you look at our data, so depending on how we define high-risk, so first of all, we can define high-risk by RSS-free. So we see that the patient with RSS-free undergoing transplant has an improved survival by transplant. However, greater survival benefit belongs to patients who are not RSS-free, who are not high risk, and yet still go through transplant. So if we define high risk by, this weighted cytogenetic scoring system using a score of more than 1, so we see that there is actually a marginal improvement of, survival, overall survival by the inclusion of ASCT. However, greater survival benefit belongs to patients who are not high risk and yet undergo ASCT. And also, if you use another definition of high risk using ultra high risk, that is 2 or more of the panel of high risk cytogenetic alteration. So use addition of autologous stem cell transplant improve survival. However, again, a greater survival benefit belongs to patients who are not high risk and yet go through transplant. So therefore, we believe that ASCT confers overall survival benefit in high risk myeloma patients. However, you define your high risk. However, and also, because this is not RCT, this is just real-world data, so we can also look at some RCT data. So I believe that the benefit of ASCT for high-risk myeloma patients is also borne out in the determination study. So this is actually, again, the subgroup analysis. So this is PFS, not OS. So this is PFS for patients with standard risk. Actually, the PFS is improved in the standard risk patient if they are assigned to the transplant arm, upfront transplant. And in fact, a greater survival benefit is actually derived for high-risk patients if they are assigned to the transplant arm. And therefore, again, ASCT actually improve survival in high-risk patients. So the next question is there any benefit for the addition of CD38 antibody in terms of PFS in high-risk myeloma? So this is Cassiopeia. So first of all, you see that these are patients high-risk assigned to VDD triplet only. So these are patients of high risk assigned to addition of DARA to VTD triplet. So it seems that the PFS is improved. And of course, these are standard risk VTD and these are standard risk assigned to the addition of DARA to VTD. So what are the passes, as Michael has already alluded to and some of the speakers alluded to. So basically they ask the question, what is the survival benefit if we add DARA to the VLD backbone in induction and consolidation and also maintenance? Okay, so we don't have these 4 survival curves. However, if you look at the sustained MLD negativity, so you see that the addition of DARA to VLD actually almost double the sustained MLD negative rate at the sensitivity of 1 in 10^6 in high-risk subgroups. Therefore, hopefully, it will translate into a PFS benefit in the future. So, and then the next question, is there a role of tandem ASCT in high-risk myeloma? So we have to go back to this EMN 0295. So basically, they ask the question if, so first of all, it showed that there is a survival benefit for upfront transplant, and also there is survival benefit for patients of receiving consolidation after transplant. However, in certain, there are some institutions in Germany who routinely perform tandem ASCT, so therefore they can perform a subgroup analysis. So if you look at patients with high risk, IMWG high risk, or patient with deletion 70p deletion, so patients with this high risk definition, if they receive a tandem transplant, the PFS is very much improved. So therefore, tandem ASCT seems to confer PFS benefit in high risk subgroup, including 70p deletion. So, and also, as I alluded to, there are some recent studies designated for high-risk myeloma patients only. So they are including the IFM 2018-04, the GMMG concept, and also this UK Optimum study. So the first one is the French study, IFM 2018-04. So the differential high risk here is actually just MWG high risk, with only the 40, 16, and 17p deletion. And this patient go with KLD induction, very potent induction, followed by a transplant, and then consolidation with a KLD again for 2 cycles, and then a second transplant. So it's a kind of a tandem transplant fashion, and they receive a double maintenance, a DARA and lenalidomide maintenance. So what about the GMMG concept? Okay, so the German study actually used another quad induction. So first of all, the definition of high risk is different. Okay, so they use, first of all, the patient has to have IS stage 2 or 3 disease. In addition, they also have to have one of the following high-risk cytogenetic alterations, including 4, 14, 40, 16, 17p deletion, or 1q21 amplification. So they use 6 cycles of induction with ESA KLD followed by single transplant, and then the 4 cycles of ESA KLD consolidation, and then a triple maintenance. Here, a triple maintenance using ESA and KR maintenance. So, and this is the UK optimal study. Again, they use a different definition of high risk. Here, they use the ultra high risk definition. They use a panel of a high risk cytogenetic alteration. So that comprises 4, 40, 40, 16, 17p deletion, 40, 20, 1p, 1q. So anybody who carries 2 or more of these high risk cytogenetic alteration are classified high risk. But they also include GEP, gene express profiling. So in case they have a high risk GEP, they also classify as high risk, and also patient with plasma cell leukemia. So with that, they use induction 6 cycles. So here, they don't use carfilzomib, they just use DARA, VLD plus cytoxin, single transplant. But a very prolonged consolidation, you see that there are 6 cycles of DARA VLD followed by 12 cycles of DARA VL, dropping the D, and then a double maintenance till disease progression. So they compare the data with their historical control. So now we have 3 designated studies for high-risk myeloma, the French, German optimum, using different high-risk definitions, different quad induction consolidation, 1 or 2 transplant, and different maintenance therapy. And then what we see is that the pre-maintenance MRD negative rate is pretty high, around 60 to 70%, and also that translates into a very promising PFS of around 70 to 80% at 3 years. So using a CD38-based quad induction transplant consolidation, double or triple maintenance, about 2/3 of the patient, high-risk myeloma patient, achieve MRD negative status, and also the 3-year PFS is around 70 to 80%, which is quite promising. So before we ask whether we should give a risk-stratified approach for high-risk myeloma, so I think the first question answers is what is high-risk myeloma in the era of this novel agent induction. Thank you so much for your kind attention.
Thank you very much, Professor Chim, for your very nice and thorough explanation and analysis of the molecular and genetic background. Now I'm opening the discussion. Are there any questions from the audience? If not, maybe I would start with one. Well, actually, how could you see in the predictable future the potential role of epigenetic factors, such the measurable parameters like DNA methylation, histone protein modifications, circulating microRNA, in the more precise definition of ultra or high risk multiple myeloma in the whole this very constellation?
Interesting question. Probably you know that I was working with promoted DNA methylation a long time ago. So anyway, I think this epigenetics is very interesting. So for instance, I think in the recent publication by Pfeiffer et al. About the MRD, they published in Blood about they use a VLD and the transplant and then the consolidation and the maintenance. And what it shows is that MRD negativity, achieving a MRD negative at the sensitivity 10 to the power 5, you see overlapping curve, superior overlapping curve between high risk and standard risk patient. However, for patients who are MRD positive, the survival is different. high-risk patient is still high risk. They got very inferior survival than standard-risk patient. Both of them are also MRD positive, and yet, the survival is different. So they ask the question, first of all, we understand that the CR rate is the same. You look at high-risk and standard-risk. The CR rate is actually the same, but the MRD negative rate is not the same. Okay, high-risk patient more MRD positive than standard-risk patients. So the question is, why are they inferior? So number one question, are they inferior when they are MRD positive? The survival is inferior. Is it because the number of tumor cells are more in high-risk MRD positive patients than standard-risk MRD positive patients? So first of all, they proved that wrong. That's not true. And the next question they ask, are the cells different? Okay, in fact, they show that the cells are different because using, RNA-seq, exome sequencing, whole exome sequencing, they show that actually, there is a clonal selection in standard-risk patients. However, there is a genomic instability in high-risk MRD plasma cells. So the plasma cells that remains are biologically different. And what they cannot show in single-cell sequencing is that they cannot show differential, mutation spectrum. So I think in that connection, your postulation may be correct. The reason that they still behave differently probably is a matter of there is a layer of differential epigenetic alteration that eventually translate into a different biology. For instance, genomic instability in the high-risk and clonal selection in standard result. I think that remains to be proven. So so I think certainly I don't have an answer for your question, but I believe that your question might be valid. But I think there are very few people who study epigenetics in terms of prognosis of myeloma, so probably it's not an easy job. Yeah, so it remains to be answered.
Yes, thank you very much. Well, are there any other questions? One more, please, if possible. Artur? Okay.
There is no on the room Professor Jerzy Hołowiecki, but he always was on this conference, and he's very, he's in the center where they are doing in such patients with ultra high risk, normally allogeneic transplantation in myeloma. What is your opinion in allogeneic in such patients?
Allogeneic transplant. Actually, I told some of you that I was a fan of myeloablative allo transplant 15 years ago. The first time when I watched that out, I was almost slapped in the face. You still do allo transplant, You're hurting your patient with GVHD. A lot of patients with GVHD, they suffer. And yet, the current treatment is improving survival so much. So why do you still do allo? So now, because I understand that actually, honestly, the survival and even the quality of life of our myeloma patient improves so much. And in fact, if you think in terms of the quality of life, the treatment-related morbidity and mortality, I think I would not do allo. Okay, as you mentioned, allo. So there's, I think that how much do you quote for TRM, treatment-related mortality for allo? Well, I think for myeloablative, usually I think it's inpatient is at least 5 to 10. And then in the long run, it may be 30 or 40%. So probably I don't think nowadays I have patients with, very weak paraprotein, unquantifiable. They live for more than 10 years with that. Still go to work, raise a family, go sightseeing. They have a very good quality of life. So I think it's a matter of your goal of treatment. And also, as I said, I like Joe McHale. He keeps saying that we are not treating myeloma. We're treating a patient. It's a person. It's not just a disease. If this is just a disease, at your guideline, whatever you have, to bang the patient with whatever you have. But it's a patient. He's got a family to raise. He's got kids. So do you want him to suffer from a lot of, complications arising from your treatment? So I think we have to, take into consideration all these things. So I think actually for me in the future, I think probably, I don't know, CAR-T probably is the way for high risk. I'm not saying for all. For ultra-high-risk patients, when they're MRD positive, it means something. Standard risk, I don't know, probably they're still indolent, but high-risk myeloma patients, when they're MRD positive, it means something. Actually, I saw patients because I was doing MRD, probably you know. So we use lympho tract. The sensitivity is only 1 in 10 to the power 5. But we see patients that who are MRD positive, they turn MRD negative after transplant, remain negative, sustain MRD negative, so they're well. But also saw patients who turn from MRD negative to MRD positive with a low level, the next bone marrow MRD increases. That heralds a clinical relapse. So I think for high-risk patients, when they're MRD positive, it means something. Probably you have to intervene, but I'm not so sure for standard risk. Probably we just observe. For high-risk patients, you do have to intervene, probably, and it has to be a clinical trial. And what to intervene, I believe it should be, well, in my take is the CAR-T. Because I'm impressed, with the data from, CARTITUDE-2B. This is, apart from the CARTITUDE-1 and 4, there are also 5 and 6 for the, newly diagnosed myeloma transplant candidates and non-transplant candidates. But they also have a very small study, CARTITUDE-2B, for, functional high-risk patients who relapse within 12 months of treatment. So I think very interesting data. The only thing I'm concerned is which CAR to give. ID cell is less effective than CAR cell, but then CAR cell has got very strange complications like this Parkinson's disease, delayed motor neurocognitive degeneration. So I think, especially the Parkinson. So I was told that is on target of tumor adverse event because BCMA is also expressed in cells in substantia nigra. But the thing is, if so, the patient has been treated with L-DOPA, Sinomax. They don't respond. And there was actually mortality even in CARTITUDE-1. One patient died from Parkinson. So despite the fact that I think the incidence of this Parkinson's disease actually decreased, was reported to be much less in CARTITUDE-4 than CARTITUDE-1 because they are probably earlier. They do it earlier, but I'm still concerned about, and I don't understand. ID cell, despite the fact that they have been reported about this delayed neurotoxicity like Parkinson, but it's quite rare in contrast to CAR cell. So do you have any comments? Oh, yeah, okay. Thanks.
Thank you very much.
Oh, thank you.
Professor Chim, for your very interesting lecture and discussion. Now I'm giving the voice to Dr. Wojciech Legieć.
Thank you, Professor Machaliński. I have a great pleasure to introduce Professor Hermann Einsele, University Hospital from Duisburg, Germany. So after the lecture, we will know how and when to use bispecifics in multiple myeloma.
So good afternoon. It's a great pleasure for me to speak at this great meeting. And I'm very sorry that because of a meeting with the GBA, I will not be able to attend personally. The topic I was given to address today is the optimal use of T-cell engaging bispecific antibodies in multiple myeloma. Now, bispecific antibodies today find a broad application in hematology and in oncology. And it was actually my team, especially Max Top, who developed the first bispecific antibody, blinatumomab, which is a CD19, CD3 bispecific antibody for the treatment of B-cell acute lymphoblastic leukemia for patients with relapsed refractory B-ALL and also for MRD positive B-ALL. And that was done in several large phase 3 trials. In addition, there are now other targets apart from CD19, CD3. So for other B-cell malignancies, the CD20, CD3 bispecifics are in clinical use and already approved. In multiple myeloma, we have bispecifics targeting BCMA and GPRC5D. And also in the setting of solid tumors, there are quite a lot of targets that are targeted with bispecific antibodies, and some of them, like tarlatamab for small cell lung cancer, are already approved and available in the clinic. Additional targets are PSCA, PSMA, and also HER2 and EGFR and MET. In addition, next generation T-cell engagers are developed, and I'm also addressing some of them. These are trispecific antibodies targeting 2 surface antigens on the tumor cells simultaneously. Now, what happens if we infuse a bispecific antibody? What we clearly see is a transient oligoclonal expansion of T cells, actually mainly CD8 positive T cells and more CD8 positive T cell effector memory T cells when compared to CD4 positive T effector memory cells. And you can nicely see this expansion is transient, and that's one of the reasons why we have to repeat the infusion of a bispecific antibody. Now, if we continue with bispecific antibody and they are actually activating all CD3 positive T cells, there is a risk of T cell dysfunction and therefore infectious complications. Now, this was the first bispecific antibody, blinatumomab, which was tested in clinical trials, and actually it was in 2005 when we treated the first patient with blinatumomab. These were mainly patients with B-cell non-Hodgkin's lymphoma, indolent as well as aggressive B-cell non-Hodgkin's lymphoma. And you can nicely see there is a dose-dependent response rate, and that especially at the highest dose level, 100% of patients were responding. The main issues of this in this trial that was mainly led by Max Top was neurotoxicity, which was completely reversible after stopping the first bispecific. Now, the first bispecific was a small molecule, a real BiTE, and this was given as a 24-hour infusion, which was not very patient-friendly, but it allowed us to stop the infusion as soon as side effects occurred. In addition to neurotoxicity and cytokine release syndrome that were nicely managed by stopping the infusion, there was also an issue of infectious complications. Now, what about neurotoxicity? There is increasingly knowledge about the mechanism of neurotoxicity. One of the potential mechanisms is that the bispecific antibody increases the adhesiveness of T cells to vascular endothelium, which activates the endothelium. The T cells are extravasating as well as the T cell engaging antibody into the CNS, where they also find target cells. There is a production of local cytokines, and then there is a transmigration of monocytes inducing local inflammation. And what is also seen as CD19 is expressed by cells in the human brain, which could be another potential cause of this neurotoxicity of BCMA targeting T-cell engaging antibodies. Another major side effect, apart from neurotoxicity and cytokine release syndrome, is the B-cell and plasma cell depletion. And already with the CD19, CD3 bispecific, we could show that there was a dramatic decrease in the immunoglobulins, IgM and IgG for at least 1 year, and with IgA persisting in some patients for several years, maybe one of the causes of the frequent respiratory tract infections seen in patients that are treated with bispecific antibodies. What we learned from ALL was the higher the tumor load and the more the patient was pre-treated, the lower likelihood there is to achieve a complete remission. So in patients with a high tumor cell infiltration in the bone marrow with heavy pre-treatment, CR rate was only 29%, which increased to 73% in patients that had a lower bone marrow infiltration and achieved 80% MRD negativity if we used the bispecific antibody as a kind of consolidation following chemotherapy, as shown here. And in this patient cohort, you can see that in patients who achieved MRD negativity after using a bispecific antibody, here blinatumomab as a kind of consolidation, these patients remained in remission for a long time period. Furthermore, there are data about AMG 420s. This was the first bispecific antibody that was actually used in the field of multiple myeloma. In this first of in-human trial, we treated quite a few patients because there was a slow dose escalation, but at the highest dose, 70% of patients responded, 50% achieved an MRD negative CR, and we had several patients with ongoing remissions for more than 1 year. Unfortunately, this again was a BICE, so that the AMG 420 had to be infused as a 24-hour infusion, which clearly is not patient-friendly, so the development went into shorter infusions times and especially subcutaneous application. And these are the bispecifics that are now available. And you can see that these are mainly bispecifics that are given IV or subcutaneously. And you can see that the overall response rate is similar to what we've seen with AMG 420. It's about 60 to 70%, and the complete remission range between 35 and nearly 40%. You can see the PFS is between 11 and 17 months. And what you can also see that the bispecific antibody, especially in the more advanced patient population, are associated in multiple myeloma with a high risk of grade 3 and 4 infections ranging up to 50% in these patients. Now, unfortunately, not all the patients are responding. When I go back to this slide, you can see that the response rate was 60 to 70%, so about 30% of patients are not responding primarily. And there are different causes. One is high level of soluble BCMA. Other one is a high tumor burden with a low E to T ratio. And there are also additional factors that induces a secondary failure of a BCMA-directed bispecific antibody. So how can we improve efficacy and safety? One issue is clearly debulking. And just to give you an example, this was a patient that we included in a trial in which a bispecific antibody was given as first-line therapy. And unfortunately, this patient had a high-risk disease, and he had also a very, very high level of IgA. So the patient developed a hyperviscosity syndrome, had hypercalcemia. And what you can also see that this patient that was studied on a bispecific antibody did not respond at all. So we measured the soluble BCMA, which was more than 1,000. So clearly from the data that we know from Lisa Bali's group that these patients are very unlikely to respond to bispecific antibodies. So we did a plasmapheresis, we gave the patient dexamethasone and restarted the patient on a bispecific antibody. And you can see that now the patient responded and achieved an MRD negative complete remission. The other issue is modulate the microenvironment to improve treatment efficacy of bispecific antibody. And we could show, and that was also confirmed by Niels van den Donk's group, that if a patient has a high level of circulating regulatory T cells, that these regulatory T cells can be activated by a CD3 binding bispecific antibody, which leads to proliferation and expansion of these Tregs, and that finally leads to treatment failure. And so the next strategy is how can we decrease the level of circulating regulatory T cells. One issue is that they are CD38 positive, and therefore treating these patients with daratumumab, with or before the bispecific antibody, is reducing the level of circulating T cells and therefore improving the efficacy of the bispecific antibody. The third strategy is to combine with IMiDs, for example, and this was nicely shown by the group of Ken Anderson, that the combination of a bispecific antibody with an IMiD can improve the efficacy of the bispecific antibody. And that was also tested in the clinic in the MAJESTIC-2 and the TRIM-2 trial, in which TEC was combined with daratumumab and pomalidomide. And you can see that using this, the overall response rate now goes to 70%, complete remission rate of 50%, and even the less heavily pretreated patients, the overall response rate reaches 94% and the CR rate 64%. So really, earlier treatment is more effective, and by combining with an IMiD and with an anti-CD38 antibody, you can improve the efficacy. Next strategy is to apply bispecifics earlier, because you can have fitter T cells because the immunogenicity of the tumor cell is better, and the patient tolerates T cell engaging therapies much better than a heavily pretreated patient. And that was the strategy that we applied in the German study groups, in which we used teclistamab in combination with dara and lenalidomide, or daratumumab, lenalidomide, and bortezomib. And what we found is that this treatment was extremely effective, and already after 3 cycles of a teclistamab containing induction regimen, 100% of patients achieved an MRD negativity. In another trial that was performed by the European Myeloma Network, MAJESTIC-4, patients that underwent an autologous stem cell transplantation were further receiving maintenance therapy with a teclistamab combination, either teclistamab or teclistamab plus lenalidomide. And again, all patients achieved an MRD negativity. So you can see that the inclusion of a bispecific antibody in induction and or consolidation maintenance is inducing an extremely high rate of MRD negativity in patients in frontline therapy. And that's why we are starting in Germany, probably still either late this year or early next year, a combination in which we combine the bispecific antibody with daratumumab Rev-Dex, and we compare these 2 arms in which bispecific antibodies included in induction and or consolidation with the Perseus trial, to see whether bispecific antibody will further improve MRD negativity rate. We are quite sure about this, but then also see whether we can improve progression-free survival. The next question with bispecific is always, do we need really to treat until progression? And what we know is that with most bispecific antibodies, already after 2 or 3 months, we have achieved the optimal response. And actually with blinatumomab, where the treatment interval was fixed, we waited until the patient actually progressed and retreated patients, and actually patients that had responded primarily had a very, very high likelihood to respond again. So maybe a response-adapted therapy and fixed duration treatment cycles with treatment-free intervals might reduce T-cell exhaustion and also reduce infectious complications. And just to illustrate this, here you are looking at trials with teclistamab, elranatamab, and talquetamab. You can see that the median time to response is about 1 month, and the median time to best response between 2 and 3 months. And there have been studies with cevostamab in which patients, after having received 1 year of treatment, actually had a treatment stop. And when looking at the data, especially patients who achieved a complete remission, none of these patients actually relapsed up to now, when after stopping the bispecific antibody after 1 year. So the idea could be patients with deep responses remain in remission after stopping of bispecific antibodies, or maybe extend the treatment-free interval. The probably not as good news was when cevostamab was restarted, only a part of the patients actually responded again to the bispecific, but this could be also due to the fact that the treatment was too long. And now looking into patients that receive mosunetuzumab, a CD3, CD20 bispecific, in which the patients only received 8 applications, and then the patients were actually stopped. And you can see that in this trial, much more patients showed responses to retreatment. And furthermore, so I think the question is, the shorter the treatment, the higher the overall response and complete remission, the longer the PFS following treatment, maybe to reduce the first-line therapy with a bispecific antibody to less than 1 year. If the patient achieves a complete remission, then restart if the patient is progressing again, could be an option. The other option is to extend the treatment-free interval, and this is based on experimental data from Marion Subkleve's group, who showed that biweekly treatment with a bispecific antibody, you induce some form of T-cell exhaustion with changes in the metabolism of the T-cell with an increased expression of exhaustion marker and a reduction in the effector function. And we could show this also in vivo, in which the patients showed a lower, higher expression of PD-1 and also of SLAMF6 when they received weekly treatment, and that the expression of exhaustion marker was much lower when the treatment interval was prolonged to 4 weeks. And we could also show that if the application was prolonged from weekly to monthly application, that then there was not only a reduced T-cell exhaustion, but we could see an increase in naive T-cells, suggesting a restoration of T-cell homeostasis. And that was also observed in a study by the Heidelberg group, in which they could show that if there was less naive T-cell restoration, that then the likelihood of a patient to respond or to long-term respond to bispecific was reduced. And so at the moment, a lot of groups now switch to biweekly or even 4-weekly intervals in patients that show good responses. And this strategy was shown to reduce the severe infectious complications from 33 to 50.6 months without having an impact on the progression-free survival. So increasing treatment-free intervals induces less infections, higher efficacy, might reduce T-cell exhaustion, and promote restoration of T-cell homeostasis and broadening the T-cell repertoire. So I think in the future, we will see either fixed duration with rather short applications, maybe less than a year, or increasing the treatment-free interval between the applications. Another issue clearly is if we treat patients for a long time, is that the tumor cells are showing an antigen loss, a target antigen loss, and this has nicely been shown for bispecific antibodies by Nisa Bali's group, Holly Lee. They show that BCMA antigen escape occurs in more than 50%. And what can we do for this patient population? Now, we have several of these patients, like this one, who beautifully responded to a BCMA bispecific antibody, went into remission for 18 months, then relapsed again. We tried different other strategies, including belantamab. When the patient did not respond, we looked for BCMA loss, and the patient had biallelic deletion of the gene encoding for BCMA. So it was very clear that the patient would not respond to a BCMA-targeted agent again. So we switched the patient to talquetamab. The patient again beautifully responded and achieved a complete remission. Unfortunately, this patient, and you see the results of GPRC5D targeting bispecific antibodies like talquetamab, like the patient that I showed you before, who received talquetamab after having failed a BCMA targeting bispecific antibodies in ADCs. And you can see that with talquetamab, you can achieve about 70% overall response rate, about 40% complete remissions, and that the risk of infectious complications is lower. But these patients have an issue of dyscrasias, skin and nail disorders that occurs in about 50 to 70% of patients. But also GPRC5D antigen escape is identified, is actually even more common when compared to BCMA antigen loss. So we need additional targets, or we have to use to apply strategies that avoid target antigen loss. One clearly is the combination of a BCMA and a GPRC5D targeting bispecific, which was shown to be extremely effective. Now we are approaching the efficacy of a CAR T cell with 96% overall response rate, 47% complete remissions, and also responses in patients with extramedullary disease. And because of this finding that the combination of two bispecifics targeting two different surface antigens, the idea of a trispecific was born. And the first one was a BCMA CD38 bispecific, a trispecific also targeting CD3. And you can see that this trispecific induced a high overall response rate and a quite high rate of complete remissions and long-lasting remissions. We need to see more data with longer follow-up, but this is clearly a very promising strategy. And then there was, at the last ESCO and EHA meeting, the presentation of the J&J 5322 BCMA GPRC5D BCMA CD3 trispecific. And this is a very attractive agent. It needs only one step-up dose. You can see that the overall response rate, especially, is 100% and achieves complete remissions in a range of 75% in BCMA naive patients. And what's also very promising is that the GPRC5D and the BCMA associated toxicity is lower with this trispecific antibody. And I think the 12 months progression-free survival rate of 95% in patients naive to BCMA GPRC5D is a really, really convincing result of this new compound. So in conclusion, bispecific antibodies are increasingly approved for the treatment of hematologic malignancies and also now solid tumors. In multiple myeloma, BCMA targeting bispecific antibodies are very effective with an overall response rate of more than 60%, a CR rate of around 40%, and an impressive PSF of 11 to 17 months in heavily pretreated patients. Combination therapies, novel treatment schedules with prolonged treatment-free intervals and earlier therapy are clearly improving the outcome of patients with myeloma treated with bispecific antibodies. And I think the first results about trispecific antibodies are increasingly are very interesting. And so these agents are increasingly explored, showing a very impressive overall response rate of 100%, a CR rate of 70%, and a 1-year progression-free survival of 95% with limited toxicity. I would like to thank you all for your kind attention and happy to take questions. Ready.
Thank you. The question is which bispecific combinations looks most promising in earlier lines. I think it is the question for a dinner because the professor is not with us. And I think that trispecifics and the bispecifics are the future, of course, in a short courses of therapy. I hope the combination with really effective in the treatment in first line, and it will be the line or the way how to cure multiple myeloma as fast as possible. And now is the place for our Ramses, Professor ARTUR JURCZYSZYN from Krakow.
Okay. Thank you. Last 20 minutes, I would like to share with you, with my presentation, about Polish algorithm for therapy of multiple myeloma in 2025. Polish algorithms are not so strange. I'm very happy about this, and also I'm very happy that in one disease everybody sees such big progress. I'm a medical doctor for last almost 30 years. When I started my career, it was only MP and VAT, as you remember. And now we have almost 30 drugs, and it is not the end. Probably, I hope I will be alive when this disease will be curable. And I would like to start from this slide where I show you our work together with Agnieszka Sporek-Kunicka, who is sitting over there. And this is our patients. We treat every day more than 500 myeloma patients in one clinic. And this disease is increasing, as you heard from India experience, and in my experience also is similar. I think in our country we have about 2 and 5,000, between 500 to 3,000 new myeloma cases, and the lifespan is still increasing. So at the moment in my country, I think we have more than 10,000 patients in one disease. I divide my talk on two parts. First part will be about how we treat in Poland myeloma patients, and another part will be about our original experience. This is how we treat. This is it could be a little complicated from people from United States because it's a little tricky. We have basic drug catalog in our country, and we have also drug program, and we have guidelines, of course. Basic drug catalog is drugs where it's available for all patients. It's simple drugs like thalidomide, lenalidomide, pomalidomide, bortezomib. So as you see, these drugs are generics mainly, and the drug program is quite limited because it's financial for special patient population. It's not for everybody, but we have possible to treat such drugs like elranatamab, talquetamab, teclistamab. We have no CARs, but I hope next year we will have. And we have, of course, Polish myeloma group, which was established 20 years ago. Professor Skotnicki mentioned about Professor Anna Dmoszyńska. She was a leader for many years of this group. And now we are doing our job. We have, of course, Polish standards, and we publish some papers about this. This is a last paper regarding new therapies in myeloma, benefits and limitations. And according to this paper, we see beautiful progress in this disease. Last 8-10 years, we see the immunotherapy. We have registered two cars. First car, IDSL, was registered 4 years ago. Siltaser was registered 3 years ago. And as MEERA told you, it could be administered in outpatient clinic. And we have also bispecific like talquetamab, elranatamab, and teclistamab, and we are waiting for more like trispecific antibodies. How we treat patients in our countries as a first line? For patient who is transplant eligible, because we still believe in transplantation, according to Cassiopeia trial, we offer daratumumab, bortezomib, thalidomide, dexamethasone for everybody. And of course, later is autologous transplantation, consolidation, and maintenance. And we are waiting for Revlimid instead of thalidomide, because according to Perseus result, it will be much better for patients, and of course, regarding quality of life, less toxic. For patients who are not transplant eligible, we normally use daratumumab, Revlimid, and dexamethasone. It's quite good results with this, and it's not so toxic. We have also other options, as you see here. We have guidelines from European Myeloma Network, from NCCN, and others, and everybody knows that daratumumab, bortezomib, Revlimid, dexamethasone is a standard of care at the moment. Last meeting, IHA and ASCO meeting showed that progression-free survival for Perseus trial could be, as Rafael told, 17 years, so it's 200 months. According to transplant ineligible patients, Cepheus trial showed that it could be 100 months. In our experience, of course, it's standard maintenance therapy. We use as a standard lenalidomide. Sometimes we use very rare thalidomide and bortezomib, but I didn't mention here, according to Perseus trial, we should use lenalidomide plus daratumumab. I hope it will be registered very soon. From transplant ineligible patients, of course, we have others option, but at the moment, it's not possible to use such option like isatuximab, Revlimid, and dexamethasone. We can use isatuximab in further lines. For second and other lines of therapy, we can use such options like daratumumab, bortezomib, dexamethasone, DARA-RD, KD, KRD. Sometimes, if possible, we can use ixazomib, Revlimid, and dexamethasone. From third line, we can use also isatuximab, pomalidomide, dexamethasone, and elotuzumab, pomalidomide, dexamethasone. And I'm very happy that from 1st of October last year, we can use also teclistamab as a third line of therapy, and from 1st of April this year, we can use also elranatamab and talquetamab. When I was in Ireland 2 weeks ago, I heard that we are a little better because Irish people have no elranatamab and talquetamab. So I'm very happy about this. And of course, from fifth line of therapy, we are waiting for other possibilities. In early relapses, normally we use DARA-velcade dexamethasone or other options like this. We are so original in our country because we use KD. KD we use in the dosage of Kyprolis a little high, like 70 milligram per meter square. But to be honest, our experience is quite good with this. Of course, we have guidelines from European Myeloma Network. This was published this year, and I will not focus on every details about this, but many of these possibilities it's possible to use for our myeloma patient in Poland. But we have also gaps in the second line. For example, we cannot use in our program DARA-KD or DARA-PD. It's a shame, I know, but it's not reimbursed at the Poland. Of course, we are waiting for this, and also we are waiting for a reimbursement CAR T-cell therapy. I know that pharmaceutical company who are producing Abecma and Carvykti, they're waiting at the moment for the approval by our Minister of Health, and probably from 1st of January it will be reimbursed for our patients. So it's very, very good. I hope it will be. Patient is waiting for this because everybody knows that Carvykti is registered as a second line and Abecma is registered as a third line. It's a little complicated regarding CAR T-cell therapy. We are not alone. For example, I was talking with our colleague from Hong Kong, and in this country also this is quite a rich country, and they have no possibility to reimburse this CAR T-cell therapy. But I'm sure it will be this possibility in future very soon. How we treat patients with late relapses in our country? We have such a possibility like isatuximab Pomdex, elotuzumab Pomdex, ERD or KRD. It's also, according to IHA and EMN guidelines, the best option, everybody knows that CARs and bispecific antibodies are, it's the best option in such situations. And we are happy that from fourth line of therapy, we can use talquetamab, teclistamab, and elranatamab. So this is late relapse treatment in our countries. And this is our original experience regarding Poland. We have POMOST trial. It was started in many centers in Poland. The population was more than 2,000. And from this trial, it was first paper published in Acta Hematologica Polonica. We focus, Dr. Grząśko focused on the population of patients who are triple class exposed and triple class refractory. From this population, it was 216 patients, and the treatment for this, it was for 59 patients. And this is a treatment administration in this triple class exposed patients. Some patients received monotherapy or 2-drug therapy, and some patients received 3-drug therapy. And the results are quite nice, I think, because median overall survival in such population are 16 months. So, in conclusion, the novel immunotherapy is the future, of course. In our country, the treatment of choice should include drugs were not previously used in the combination. Repeated drugs in previous lines treatment is suboptimal. Monotherapy, it's not the best option in such population. We have also gaps in risk-adapted strategy. In this international high-risk cytogenetics influence therapy at every stage, consideration tandem transplantation, inclusion bortezomib maintenance, and earlier use of aggressive treatments. And we have some gaps in frail elderly patients management. Not only it's Polish problem, it's international problem. In our drug program, we can use general for this new drugs with ECOG 0 to 2. So for very frail population, it's not possible to use these drugs. This could represent eligibility gap through the practice physicians may overestimate performance in treatment. We have also some gaps in the diagnostics. For example, NGS is not financed from public sources. In some centers, we have problems to use PET-CT and MRI. And we know that this is the standard of care. The Polish National Multiple Myeloma Therapy Program has made remarkable progress in mirroring international standards, particularly by finding novel agents. Of course, this is Darzalex, isatuximab, carfilzomab, and bispecific antibodies. They were previously unavailable. Patients with new diagnosed multiple myeloma now receive therapy on par with global recommendation, bearing some adjustment like broader access to quadruplet therapy. This is a standard of care at the moment. Relapsed patients have access to most key drug classes through the radical criteria may delay optimal regimen used in certain sequences. The primary gaps to address moving forward are broadening access to CAR T-cell therapy. We are waiting for this, integrating formal risk-adapted and frail-adapted algorithm. This is our Krakow. For last 5 minutes, I would like to share with you about our Krakow research interest in the field of multiple myeloma. It's two areas. Role of physical activity, I think is very important, and exposure to environment factors in multiple myeloma. Some of these projects will be in the future. The role of physical activity is very important. I show you the papers which was done by my PhD student some time ago, and she focused on Nordic walking training and gut microbiota, VNT signaling, iron metabolism, calcium phosphorate metabolism. So it's very nice proof that, for example, patient with Nordic walking group showed statistical significant decrease in mean serum myoglobin concentration and increase in vitamin D. Also, regarding iron metabolism, the Nordic walking training cycle positively influenced levels of MRI genes associated with iron metabolism. I think Nordic walking training is safe and beneficial form of physical exercise for our patients. For the last 5 years, this is our original work in Krakow. We have the leader, the master of Nordic walking, and every week our patient is treated like 10, 20 patients every week, 2 times in the Monday and Wednesday, and it works, I'm sure. Another is lifestyle and environment exposure and risk of myeloma. It was a paper published by Dr. Suska a year ago. It was multi-center case control study from 20 hematology centers and 5 primary care centers in Poland. It was 270 new diagnosed myeloma patients and 2 anti-controls. It was the idea was to assess association between lifestyle and environmental exposure and risk of myeloma. So from her work, regular physical activity is protective in myeloma. And I think it's very important, and other lifestyle factors like alcohol, stress, smoking, BMI showed no significant association for multiple myeloma. And we established 7 years ago Krakow Myeloma Support Group, and we have nice meeting every week, every month, every second month, and this is a picture for a last meeting. And my last slide is from Luciano Costa, our friend from Alabama, who a couple of weeks ago showed how to treat the bottom line in new diagnosed multiple myeloma in 2025. I like this picture, and I would like to show you that for everybody at the moment should be everybody should be treated with IMiDs, the basis, of course, Revlimid and Darzalex for all. For most, we should use also carfilzomib or bortezomib, and autologous transplantation for some, as you see. The future is unknown. Only Nostradamus knows the future, of course, but I think the future will show that myeloma will be a curable disease. Thank you.
Thank you very much for this interesting lecture. Are there any questions, any comments? Michael? Yes.
First of all, Arthur, I'd really like to congratulate you and your colleagues for really providing, fantastic access to a really wide range of treatments for your patients. And I think, I look in envy at some of what you're able to do, and hopefully we're catching up with you, and hopefully soon we'll have the same access as you have. But my question actually relates to Carvykti. So you mentioned that you hope that from early next year that you'll be in a position to provide Carvykti, but you emphasized the fact that it is available or reimbursed for second-line use. And apart from the approval or where it's actually, it can be used, there's a practical issue of access. And do you know how many slots you actually have available for Poland? And if you have a limited number of slots, how are you going to decide how to use those slots? Where will the emphasis be? Will it be treating patients who are, in their fourth line of therapy, or patients who are, relapsing from primary therapy?
Very good question. Thank you for this. To be honest, the answer is I don't know. But I think my feeling is that it will be very, very limited. Probably, Wojtek, correct me if I'm wrong. Probably, Minister of Health could approve only 5 centers in the Poland. It will be probably Lublin, Warsaw, Wrocław, Poznań, and Gdańsk. So I think globally in my country it could be therapy for like 100, maybe 200 patients per year.
Yes, we are still establishing the program now, and we expect to finish the end of the January, I think. So I doubt it will be the 1st of January. And the promise of one of the company is to construct the second manufacturer in Europe, and it will be the answer for your questions. So the slots, probably we will have them bigger.
Because I know that Greece is also waiting for this. Many countries is waiting for this. So as you told, we need another factory. Maybe
yes.
Maybe not one, maybe 3, maybe 4. Because the population of myeloma, as I told, it's 3,000 myeloma patients in this country. Everybody relapse probably, but after this, the best therapy as a first line, the relapse, it could be like after 15 years. So we can wait for 15 years and we can build another 5 factories during this time.
So maybe it will be therapy for every patient with multiple myeloma.
Yeah.
The best therapy as the first line. We are still waiting for the result of CARTITUDE-5, yes. We are still talking about how to shorter the bispecific regimens. So it is really difficult to say, but I think actually the second manufacturing is absolutely necessary in Europe.
Everybody knows that it's possible to use this Carvykti. It's no problem in Germany, for example. I know that we sent a couple of Polish patients also to Germany for this, but normally it's the answer is that it's a queue for German people, and they are not happy to accept Polish people or other. So we should do it in this country, of course. But it's not so easy because the one factory for Europe is for sure too little.
Well, Artur, your devotion to the patients is very widely known, not only in Poland. However, you also mentioned on some cause and effect connection between Nordic walking, microbiota, and very nice other points. Mm-hmm. Well, this is very important under the angle of the immunologic background. What do you think? How it could be influenced by additional step forward, like a recommendation of the diet, recommendation of the prebiotic, postbiotic, probiotics, just like supplementation with D vitamin. There is still increasing data on the potential connections, association with the incidence of multiple myeloma, the response for the treatment, and very such points.
The physical activity absolutely is very important in such a group of patients. The Nordic walking is a proof that it's a beneficial for these patients, and the sport. It's very unusual to recommend sport for patients who has broken, legs or etc., broken something. But it's 80% of these patients could do it, I think. And we are doing this, and on this room, I know that some patients can tell that it works. And I think regarding immunology stipulation, I think lymphocyte T is increasing after every exercise. It works. It's good for patients.
Thank you very much. Are there any more questions?
Yeah. How I train?
Yeah, for the Nordic walking training.
We have, a guy who is a professional. He's a doctor regarding physical academia, and he's a master of the world, to be honest, regarding this discipline. And the patient is starting to treat on Monday at 10 o'clock, and on Monday at 5 p.m. It's 1 hour. It takes 1 hour, and on Wednesday also it's 1 hour. So it's twice a week, and we started from 1st of April, and we finished this from 30th of October. This is during periods where it's safe regarding weather. We are not doing this during winter. And I think regarding these papers, it works in many areas. Yeah. It's outdoor, yes, it's outdoor. It's, it's, I can show you, isn't it? Yes, Nordic walking, yes.
Mike.
Have you looked at butyrate? Have you looked at butyrate levels? If from the effect on the microbiota, butyrate could potentially influence immune function?
We should do it. We didn't do it. It's a good idea, isn't it? Yeah. Okay.
Thank you very much, Artur. Well, we are finishing the session. Together with my co-chairman, I would like to thank all the speakers for their very interesting, nice lectures. I think Artur would give us some concluding remarks from the conference at the end.
Thank you for coming to Krakow. It was a great meeting, I think. I hope we'll meet next year. And in 10 minutes, I would like to invite you for a walk to Krakow Philharmonia. They're waiting a bus, and we are going to Koszkiew Castle, very beautiful medieval place, and I invite you for a dinner. Yes. Thank you.
Good afternoon, dear professors and guests. On behalf of hematology patients, I would like to say thank you for coming to Krakow. Thank you, you take part in this conference. It's very important for us, especially for MA patients, to hear about the new ways of treatment, to your discussions and presenting the new ideas. Thank you very much, Professor ARTUR JURCZYSZYN, for organizing such events, very interesting event each year. Thank you for your taking care of us. Thank you that you always help us in any time. Thank you for your optimism and smile. Thank you very much. Dear guests, enjoy your time in Krakow.
Thank you very much. Thank you.
I would like to say something from the side of patients. I'm not suffering but my wife is the patient of Professor JURCZYSZYN, and I would like to express my deepest respect to both Professor Aleksander Skotnicki and ARTUR JURCZYSZYN, to their hard work, because thanks to their work, the patients are treated according to the recent achievements in the scientific, what I would call, struggle against And they've got comfort, they've got the feeling of really particular care. I should add also that they work in, gently saying, far more modest environment than I believe you've got, Professor, in Arizona Center. And the achievement is, basing on that, really spectacular and outstanding. And Professor Skotnicki has made, in my opinion, very adequate reference to Nicolaus Copernicus, the famous student of the Jagiellonian University, who, as we know, one day stopped the sun and moved the earth. And having listened to all these scientific papers you've produced us, I've got the impression that all of you, you've got the same target, and the target is to annihilate which obviously to a certain extent would be similar to the finding of Nicolaus Copernicus, to stop development of This is something what I want to wish all of you who participated in this conference, and also to all the hematologists around the world. And one thing more I wanted to add, what I have already mentioned to Professor JURCZYSZYN. He's a perfect organizer, and I said prior to the conference that you must have perfect relations, very, very high, because he arranged the conference and arranged also fantastic weather for today's conference. No heavy rainfalls, and also no tropical temperature. Thank you for this also, Professor. Anyway, thanks a lot.
Thank you. So again, thank you for coming and see you next year, I hope. Thank you. Okay.